So any announcement, Vanessa? Vanessa, do we have any announcements?
سامي هلا نحن ما بنسمع بس في فويس للاتنديز، نحن البانيلست هول ما بنشوفهم.
Yeah, and I would like to know from Vanessa if we have any announcement, or should I start immediately?
Doctor, you can start.
Should I start?
Yes,
Yes.
doctor.
Yeah, so good afternoon. I would like to welcome all our speakers and chairpersons and all our participants from MENA region. So it's my pleasure, and on behalf of CRG, Dr. Fadi Farahat, and AMAC, myself, to give the introduction to our today ABC Oncology educational course about hematological cancers. All of you know that the activity is endorsed by AMAC, UICC, and ASCO, and it's awarded by 2 CMEs. So I will present the chairperson of our course of today, Professor Ahmed Ibrahim. He is the head division of hematology oncology at Maqasid General Hospital and director of
Dr. Ibrahim, qui est
Maqasid General Hospital and president of Lebanese Society of Hematology and Bone Marrow Transplant in Lebanon. Please, Dr. Ahmed, the floor is yours.
Dr. Ahmed, you are muted.
I am unmuted now. So, good evening, everybody. Thank you for inviting me to chair this session. This is a 3-hour session almost on oncology, an ABC oncology session on hematological malignancies. I would like to thank the organizer and to thank also the Novartis, Takeda, and Pfizer, and for endorsing this and covering this event, and also for Sciences Po for the organization. I would like to thank Professor Sami Khatib and Professor Fadi Farhat for inviting me to be the chairman of the session. This is a session where we will discuss about, we'll discuss many hematological diseases. We have speakers from Lebanon and the region, friends of us, and they are expert in their field. We will talk about multiple myeloma, we will talk about CML, we will talk about Hodgkin's, we will talk about the MPN, particularly myelofibrosis. So the first speaker is Professor Jean Sheikhi, the Associate Professor of Clinical Oncology and Hematology at the American University of Beirut. Jean is well known in the field of bone marrow transplant. He is an excellent hematologist, friend of mine and us, and one of the pioneers in the bone marrow transplant in Lebanon. Jean will talk about management of patients with multiple myeloma beyond the clinical trial setting, understanding the balance between efficacy and safety, tolerability and the quality of life. So Jean will have about 30 minutes presentation and discussion. The floor is yours, Jean.
Thank you, Ahmed, for this kind presentation. Good afternoon, everybody. Thank you, Dr. Sami Khatib and Dr. Fadi Farhat, in this continuous medical educational meetings. Can I share the screen?
Yes, doctor.
Okay. Did you see my slide?
Yes.
Okay. So good afternoon, everybody. Again, I want to summarize.
We don't see the slides.
I am in full screen actually now.
Yes, we are seeing the slides, Doctor.
Yes, so we have the slides.
Okay, so I can start.
Yes.
So I will try to summarize today a very difficult topic related to the continuous therapy as a treatment paradigm in multiple myeloma patients. So initially, some epidemiology of multiple myeloma. It's basically the median age is above 69 years. So elderly patient is most common in men. As you can see, the evolution of the survival patient with multiple myeloma drastically changed in the last 5 years. With improvement of the survival due to the improvement in the diagnosis and basically with the new drug in multiple myeloma. So this is the chart of my presentation. We will talk about multiple myeloma, why the continuous therapy in multiple myeloma, the rationale for a proteasome inhibitor in multiple myeloma, challenges staying on therapy, strategies to potentially overcome it. We'll talk also about tourmaline study, and finally about the clinical decision making in a relapse refractory multiple myeloma patient. So it's very important for us knowing that multiple myeloma is a chronic disease now, so it's a marathon in the treatment and not a sprint treatment. We have different stages based on the stage of the multiple myeloma. We have the first line, we have the first line for symptomatic patient. Maybe we have a duration with the plateau and remission. After the first relapse, we have the second line and the second relapse. As you can see, we have different relapse and multiple lines of treatment. Most patients with multiple myeloma eventually relapse due to the presence of a residual disease. More the minimal residual disease is deeper and negative, the percentage or maybe the duration of the response is longer and the relapse rate is lower. Why the continuous therapy? The continuous therapy is an evolving paradigm. Why? Because we need a continuous therapy for the chronic disease, as I said before, for multiple myeloma. First, because we need to prevent the relapse and maybe to control better the clonal population of multiple myeloma. So we need more cytoreduction and minimal residual disease elimination. So we need to go deeper to treat the disease and to maintain this remission as long as possible for those patients. What about the limitation of this strategy? We need more selection of the treatment-resistant clone. We need, did this treatment is feasible, especially for the elderly patient, non-fit patient, the frail patient, the burden of administration and the patient status, performance status, the cost of the therapy, especially in our Middle East country and outside the Lebanese and financial crisis actually. And finally, our limitation for subsequent therapy choices. The second point is related to the clonal evolution through the disease course. As you can see, the clonal advantage after each line of treatment, we have this clonal selection, not specific to multiple myeloma, but also in different disease, also in acute myeloid leukemia, acute lymphoid leukemia, and lymphoma. But in multiple myeloma, you can see after each relapse, a different evolution of a different clone, a competition selection for the bone marrow niche, and finally, a migration and founder effect with maybe a different tumor cell diversity after each line of treatment due to this genetic evolution. So potential benefit of continuous therapy is to perform a clonal suppression and to maintain the disease control. Basically, the competition with the bone marrow niche to avoid an early relapse and to prolong the duration of the response for this patient. So when we suppress initially with the induction therapy, maybe with the autologous stem cell transplantation, the consolidation after transplant, we need a maintenance therapy to continue the control of the disease and to transform the disease to a chronic disease with maybe some indolent clone. It was the initial objective with the maintenance therapy post-autologous transplant with lenalidomide. So the feasibility of this continuous therapy to increase the overall survival rate, and maybe the second point is the time on treatment. It's increasing in the last year. When we compare the survival before 2010, or maybe let's say after 2006, the arrival of the new drug, proteasome inhibitors, the IMiD drug, so you can see that the survival changed drastically after this new drugs. However, we need to balance the new drugs, especially in combination of different new drugs, the doublet, triplet, or quadruplet regimen for the first line for the relapse patient, and maybe fit patient eligible to transplant, but also for elderly, non-fit, non-eligible to transplant, and to combine the efficacy of this drug with the tolerability and the toxicity of these drugs. What are the effects of early discontinuation due to adverse event? In this meta-analysis in different European trials, MP versus MPT, the VISTA trial, BMP versus VTP, or different combination in over 1,435 newly diagnosed patients with multiple myeloma, you can see the drug discontinuation due to adverse event affect drastically the overall survival. So we should have different consideration for the continuous therapy. First, we need an efficacy for this continuous therapy regimen, and should include also the tolerance. This toxicity should be manageable and maybe reversible after the discontinuation of the drug. A convenience of administration, basically oral therapy is preferable compared to IV medication, and finally, no adverse impact on the quality of life of this patient. So what is the rationale now for the proteasome inhibition in multiple myeloma? We have I'm talking about this. Why? Because we have different and multiple drugs actually available in our countries based on like bortezomib, ixazomib, oral proteasome inhibitors. We have carfilzomib or maybe oprozomib, and finally marizobim. We have the development, let's say, of proteasome inhibitor and the treatment of multiple myeloma began since more than 20 years ago with this phase 1 trial published by Robert Orlovsky. And we have in 2003, the phase 2 study bortezomib in relapse refractory multiple myeloma patient published in New England, and followed by the approval of the drug in 2005 after the APEX study, and the combination with melphalan and prednisone for the treatment of multiple myeloma published by Jesus San Miguel, and the VISTA study for the elderly patient in 2008, non-eligible to transplant. And recently we have the new with Philippe Moreau in Nantes in France. We have the phase 3 with the development of subcutaneous versus intravenous administration of bortezomib in multiple myeloma relapse refractory in 2012. And the phase 2 study for the new agent carfilzomib in patients with relapse refractory multiple myeloma, and so on. Combination carfilzomib, Revlimid, dexamethasone for refractory relapse multiple myeloma 2014, and Endeavor study, so we have finally the oral ixazomib combined with lenalidomide and dexamethasone for multiple myeloma, the Tourmaline study, and I will talk about the update of the study extensively. So the multiple myeloma survival, as I said before, improved after the introduction of the new drugs, basically after the introduction of bortezomib. You can see the difference in terms of progression-free survival before 2005 and after 2006, and in terms of PFS and OS. So what is the challenges due to the staying on the treatment and strategy to potentially overcome it? So prolonged duration of treatment, surely it's important and maybe necessary for this kind of disease. However, we should balance the efficacy, prolonged efficacy, with the tolerance of the new drug. So as you can see, for the long-term continuous therapy is associated with a better outcome in terms of PFS and overall survival. However, the real-world duration of treatment can be lower than that seen in clinical trials. And especially, and I can add that the clinical trial is totally non-applicable maybe in our population, in our countries, with our different problem due to the accessibility of the drugs, the financial burden, and third-party payer coverage for our patients. So the duration of treatment estimated were significantly lower than those reported in clinical trial, and due not specific for one drug, but maybe in different type of drug, IMiDs or proteasome inhibitors, chemotherapy, or old or new generation therapy. So the main concern for the proteasome inhibitor, especially for the Velcade, in newly diagnosed multiple myeloma, you can see that we have the peripheral neuropathy is an important consideration, especially grade 3 or above, with 33% of the patient. However, for relapse refractory multiple myeloma, the peripheral neuropathy with ixazomib in the Tourmaline study is less than 2%, and with carfilzomib is around the 3%. How can we improve the way of proteasome inhibitor are used? As I said before, we have different available drugs, all the bortezomib IV or sub-Q, carfilzomib only IV, ixazomib oral, and the new oprozomib is oral with different and multiple schedule of administration. What about the study published by Philippe Moreau in New England? Ixazomib oral oxazomib with Revlimid dexamethasone for multiple myeloma. It's a one-to-one randomized study. Ixazomib versus placebo plus lenalidomide and dexamethasone. The classical regimen, 4 milligram once weekly, day 1, day 8, day 15. For ixazomib, and classical regimen for lenalidomide and dexamethasone. The primary endpoint is the PFS, and the secondary endpoint, overall survival. Overall survival for high-risk patient with deletion 17p, and overall response rate, CR, VGPR, duration of response, etc. The baseline characteristics were balanced between the group IRD versus placebo RD. And you can see that we have a significant 35% improvement in terms of PFS in the IRD ixazomib Revlimid dexamethasone group compared to the placebo group. The median follow-up is around 15 months in both groups. This PFS benefit across all the subgroup analysis for age, young, less than 65 and above 75 patients, independently from the ISS stage stratification, the risk, cytogenetic risk, standard and high risk. You can see all this subgroup analysis are in favor of ixazomib compared to the placebo and RD. So ixazomib Revlimid dexamethasone seems to cancel the negative impact of the high-risk cytogenetic, especially deletion 17p and 414 alone. As you can see, for those patients considered as high risk, when we add ixazomib to the Revlimid dexamethasone, the high-risk patient had the same outcome compared to the standard risk patient, which is very important, this efficacy of this total oral therapy, ixazomib oral, Revlimid oral, and dexamethasone oral. So we have also a consistent PFS benefit with IRD regardless of the prior therapy. Either the patient received proteasome inhibitors, or maybe IMiDs, or combination, or maybe a refractory to bortezomib or any other proteasome inhibitors. This combination ixazomib RD improve also the response rate and time to progression compared to the placebo. We have 21 months here for the IRD compared to 15.7 months with the hazard ratio 0.71. This combination also response is deeper over time after each cycle compared to the classical placebo RD. The overall survival interim analysis after a median follow-up of 2 years, the median overall survival was not reached in either arm. We have the similar rate of treatment exposure and discontinuation between the two groups, and we have mainly the similar rate of adverse event between the two groups. So this combination IRD has the same side effect and adverse effect compared to the placebo RD. What about the quality of life? We can see either after the evaluation, quality of life by AORTC criteria or multiple myeloma MY20 is a questionnaire to evaluate the quality of life of this patient. There is no difference between the two groups. What about the clinical decision related to multiple myeloma with refractory relapsed disease? We have actually multiple options. It's not like 15 years ago, before 2006, when we had VAD with transplant, cyclophosphamide, and melphalan, basically. Actually, we have different families of drugs, the IMiD, lenalidomide, thalidomide, pomalidomide. We have the proteasome inhibitor, bortezomib, carfilzomib, morizumab, and many other, ixazomib also. We have the HDAC inhibitors, we have the monoclonal antibodies like daratumumab and elotuzumab. We have the vaccine, and we have the checkpoint inhibitor, and finally the CAR-T cell therapy for refractory relapse multiple myeloma. We have different actually options available for those patients. But what are, the question is, what are our goal in the treatment of refractory relapse multiple myeloma? So we should have this balance between the short-term response to achieve a rapid, complete response, or VGPR maybe, and after to maintain this response as long as possible to prolong progression-free survival and overall survival. And through this option, we should balance through the toxicity, lower toxicity, and optimal quality of life. So we need a continuous treatment regimen for the multiple myeloma to achieve favorable long-term outcome balanced with minimal toxicity and maintaining a good quality of life. So the treatment decision factor should be based, it's very important, based on the disease characteristic, taking into consideration the prior or previous treatment, and finally the patient characteristic. So disease characteristic based on the cytogenetic risk, the abnormal or organ dysfunction like kidney function, cardiotoxicity, neuropathy, extramedullary disease, prior therapy, progression on therapy, or maybe toxicity associated with the prior therapy. And finally, the patient characteristic, performance status, comorbidity, age-adjusted comorbidity, performance regarding treatment administration, and finally, the goal of our treatment to achieve a complete response, or maybe to stabilize and to have a durable response for those patients. It's very important for us to discuss also when we talk for continuous therapy, so treatment until progression, we should take into consideration the cost of the treatment, the direct cost of the care, chemotherapy procedure, test, analysis, the health insurance co-payment, deductible out of pocket for our patients, especially in the Middle East and Arab country, the travel and expenses, loss of retirement saving, the impact on the employment, time and commitment, the type of administration of the drug, especially for the elderly patient, and especially the distance from the clinical centers, and the patient may be living above 40 miles to the medical facilities. So the economic burden on our patient and the caregiver is substantial. We did, I did a executive master in the health system and the hospital management. It's very important to evaluate the cost of this treatment for our patient, not for 1 year or maybe 2 years, but when we talk to the continuous therapy and maintenance therapy for more than 5 years, we should take into consideration all this aspect, a global aspect, and to make some consideration for our medical and economical and pharmaceutical studies. So the number of multiple myeloma patients are typically underrepresented, as I said before, in clinical trial. Why? Because we have more selected patients for the clinical trial. The patient with comorbidities or maybe advanced stage or elderly patient, frail patient are almost excluded. The patient from lower socioeconomical background also, ethnic or racial minorities are also excluded. So finally, as I demonstrated before, the total oral therapy is excellent with a 6 months increase in PFS. We have improvement in overall response rate, especially for the high-risk cytogenetic patient, limited or minimal additional toxicity, excellent quality of life. And we need more and longer follow-up to demonstrate this combination or total oral combination for multiple myeloma patients. Thank you for your attention, and I'm happy to receive any question from the audience.
Thank you, Dr. Jean, for this extensive and interesting presentation. We will leave the question to the panel discussion at the end. Now we move to a hot topic, minimal residual disease in multiple myeloma. So we have 5-minute presentation by Dr. Samir Yasser. He is consultant oncologist in King Hussein Cancer Center in Jordan. So Dr. Samir, the floor is yours. This is a hot topic, and I think at the end we'll have any question about minimal residual disease in multiple myeloma.
We have 15 up to 20 minutes, yes?
15 minutes now,
yes.
15 minutes presentation, and we will have 15 minutes discussion at the end after your presentation, Fadi, on the guidelines of the treatment of CML.
No, I mean to Dr. Samir, you have to give
15 minutes
time because it's very interesting topic.
Yeah.
15 minutes.
Thank you very much.
We are on time.
Yeah. First, I would like to thank you all for inviting me to take this opportunity to give the talk on really a very hot topic in multiple myeloma. I wonder if you can see my slides.
Yes, we can.
All right.
But it's not in. If you click on F5, please.
Is it moving?
No.
No.
And it's not in slide view.
لا أنا على slide view عملت.
I am seeing your slide. We have your slide on slide view.
عم بحرك فيهم بتشوفوهم.
لا.
I'm changing.
We have only بدك تحطها slide view F5 مثل ما قال لك فادي لأنه عم نشوف the other slides the slides واحدة ورا واحدة على الطرف. فأنت if you put on F5 you will have view of the slide. هلا you are moving يعني عم نشوف الثاني.
بس أنا لما بحط slide view اللي هو ما يعني slide show عم أنا بشوف السلايد بيتحرك بس أنتم مش عم بتشوفوه بيتحرك.
حرك تشوف.
هاي عم
سيانس برو فيكم تساعدونا؟
خلي سيانس برو تساعدنا لسه.
Doctor, can you send me your presentation so I share it from my side?
لا, now we can see it moves. It moved now, Dr. Samir.
Move Dr. Samir تنشوف. Dr. Samir, move تنشوف.
Okay. Is that
now? It's good.
All right. I have nothing to disclose.
It's not yet. It's not yet in.
It's not in the slideshow, by the way.
Yeah, that's what I'm saying.
I will try to stop sharing. I'll try to share it again.
Okay.
يمكن if you
بكل الأحوال it's very nice to hear from from our colleague Dr. Sam from Urdun, from Jordan, and I think it's very hot topic. What you have as comment?
MRD negativity is now the hot topic of multiple myeloma, and as Dr. Jean show us also, outpatient therapy of multiple myeloma is also another hot topic with the new drugs.
Just if you allow me in 1 minute, just to say that we have translation from French to English and from English to French, and just to announce that our next activity will be in onc cancers. Next session will be in November.
In
12th,
what? When?
In gynecological cancers.
Where?
In November.
Where, Sami?
In
ABC. What? The ABC course.
Yeah, okay, online.
Yeah, the ABC course online.
I think in the future you have to think about hybrid with corona. Hybrid will not be bad in the future.
Yes.
There are a lot of attendees.
Yeah, inshallah.
You exceed into 100. Every time I'm participating to ABC, there are a lot of people who are sharing, who are participating, who are attending.
Yeah, inshallah, next time we'll do it.
Yes.
عم بتشوفوا السلايد بيتحرك؟
No, doctor, and we are not seeing the full screen.
طيب شو المشكلة؟ أنا مش عارف بصراحة.
Can you put على slide show تحت على اليمين, you know it.
أنا حاطط سلايد شو دكتور فادي، حاطط بس مش
حاطط مش طالعة. Do you mind إذا we can share it from Science Pro?
أبعته هلا أي إيميل؟
لا معكم إياها Science Pro ولا لا؟
No, doctor. Dr. Farhat, if you want to, you can start with your presentation. So Dr. Sami can see his presentation and I share it from myself.
Okay. طيب فإذا أحمد أنا.
So we'll go to the presentation of Fadi, no?
Yes.
طيب, now it's a pleasure to invite Professor Fadi Farhat to talk about CML. Professor Farhat is the president of the TRG-CG. He is the head of the Hematology Oncology Department at Hamoud University Hospital in Sidon, Lebanon. And Fadi with Dr. Sami are doing a lot to promote education through ABC series and presentations. You are hearing me, you are seeing me. So Dr. Fadi will talk about ELN guidelines for the treatment of newly diagnosed CML. And he will do also a review for Ponatinib data in first line in CML. So the floor is yours, and you have 30 minutes, Fadi.
Okay, I will not take 30 minutes. I think it shouldn't be so long. You are seeing my slide. You are hearing
29.
Okay, thank you very much. Thank you for all the attendees. Really, thank you, and thank you for the support of speakers and the panelists. So thank you, Vanessa, for this photo. She found this photo. Now I will be talking about the ELN guidelines, some updates, and we'll talk about TKI and patient-related factors that may affect the choice. And finally, I will consider the Ponatinib. Why Ponatinib? Because it's the newest arrival. It's the latest coming to the markets. What about ELN guidelines, European Leukemia Net 2020 compared to 2013? First of all, now the ELN consider that ELT's score apportions fewer patients into high and intermediate risk groups than the school score. So previously we used many different scores. Now the ELT's score is the most prevalent. For the early treatment milestones, we used to say that we need a BCR-ABL level less than 10%, in approximately 6 months. Sorry. Now we say that we should have the BCR-ABL1 transcript level more than 10% at 3 months. and it should be confirmed. Treatment-free remission didn't exist at this time. Now we all try to push our patient to get this opportunity of the of a TFR. It's a goal for our doctors and for our patients. The guidelines recommend the consideration of TFR in appropriate patients, and we have to discuss it for sure with our patients. The recommendation of the treatment, we started, as you know very well, with the first generic, then we went for dasatinib and nilotinib. It's in 2013. And now we included the generic imatinib and also bosutinib. The second line and subsequent line, we had the imatinib, dasatinib, nilotinib, and bosutinib for those patients. And we have also ponatinib that was recommended for second line or for patients with mutation T31 315I. Now I start with the ponatinib, and you can see it in bold. The ponatinib is no longer a second line, and the bosutinib is now included as second line recommendation and also as first line. But so the bosutinib has its place now. It's like the imatinib, dasatinib, nilotinib in first and second line. How do we select the TKI first line treatment? We try to think about the comorbidities, the contraindication for patient. So we should know well our patient. We should think also about the efficacy versus safety, which means we have to get a major molecular response. We should go to a deep response, but taking in consideration the safety. And the TFR eligibility versus long-term management is now a treatment goal. And indeed, in some cases, well controlled by imatinib, I'm suggesting them to move to a second generation in order to propose the TFR. And we can debate it during the discussion. Because the TFR is only, I think, with second generation TKIs. Now we go through each of the drugs. Imatinib, there was no contraindication, no absolute contraindication, no life-threatening complication, just a patient with cardiac ejection fraction low and GFR low should be monitored. And here you can see that if I show the summary of the recommendation on based on patient comorbidities, the only limitation was the cardiovascular. I mean, the only contraindication might be the cardiovascular event, but with the limitation, and renal impairment also with limitation. So as you see, imatinib is really one of the most tolerated drug nowadays from the start. Now, dasatinib, we can see that the ALN recommendation showed a strong contraindication, the respiratory failure, the pleuropulmonary disease concomitant or previously, and the pericardial disease. If we look to the summary of recommendation on appropriate consideration based on patient comorbidities, we can see that also for sure with the risk of pleural effusion, lung disease is a strong contraindication. The pulmonary arterial hypertension is a limitation. The pericardial disease is a strong disorders is with limitation. The hypercholesterolemia with limitation. So you see all what's related to the cardiopulmonary problems, and also might impact the use of the drug, and in some case specifically in case of lung disease, it's a strong contraindication also in pericardial. And the competitor of the dasatinib is nilotinib. The summary of ELN recommendation based on the contraindication, strong contraindication for coronary heart disease, cerebrovascular accident, peripheral arterio-occlusive disease, pancreatitis, history of pancreatitis, even if it's not active, hypertension, hypercholesterolemia, and diabetes. So this is the list, and a strong contraindication for cardiovascular problems and pancreatitis, while a limitation of use in case of hypertension, hypercholesterolemia, diabetes, and hepatotoxicity. So we are running, and now on each drug. So as we say always, when you treat a patient in oncology, hematology, it's not only about efficacy, it's also about tolerance, about toxicity. So you have to choose your toxicity, the toxicity profile that fits your patient. Now we come to the bosutinib, al-asghar sinnan, the newest drug. In the ELN recommendation of 2020, there is no relevant comorbidities or strong contraindication, which is good. And if we look to the limitation or to the comorbidities that will help us choose the appropriate TKI, we can see that pancreatitis, hepatotoxicity, and diarrhea are considered with limitation. So really, it seems that we are not getting a lot of toxicity. And when it comes to ponatinib, we know that now it's included as a third and more line, and in the patients carrying a mutation T315I. Now we have to look also to the limitation and contraindication. It's again cardiovascular, hypertension, hyperlipidemia, and diabetes. So the ponatinib is a medication that should be used in later line and also have some limitation and some contraindication. So now that we discussed the comorbidity, the patient-related factors, we also discussed the efficacy versus safety, and we should talk about our treatment goal, which should be the TFR eligibility. So nowadays, whenever you have a patient, you have to think about the option of treatment-free remission. In summary, just to show again that the 2020 Eln Guidelines included recommendation on appropriate TKI consideration based on patient comorbidities. So that's again repeating what we have said, and that it was included. Now we will talk about the bosutinib because it's one of the new drugs, and indeed, even though we have a number of CML patients followed in our department, but the experience with bosutinib is not really the biggest because it's new. Just to mention that it's approved in European Union, United States, and Japan with different indication. Here it's for the newly diagnosed and for second line, and also it's for in Japan it's indicated for all. Okay. Now the bosutinib has been studied as always in second line first, and the efficacy was confirmed and the safety was good. So I will move directly to the first line because I think it's the major advantage, and it's the B4 trials where we can see that the MMR and CCYR rates are significantly higher with bosutinib when they are compared to imatinib. So the trial is a comparison between both drugs, imatinib versus bosutinib. We have the same number of patients, and we can observe that the MMR is higher in the bosutinib, and the complete cytogenetic response also is higher, 77 to 66, and always the p-value is significant. We still are comparing with imatinib, the oldest drug, while I think it will be good to compare the new drugs together, like bosu to other new drugs. And when we check the Eln guidelines for this BCR-ABL more than 10% at 3 months, we know that we should change whenever there is a failure to obtain a BCR-ABL1 level less than 10. So as you can see, at 3 months, we have to change if the treatment goal is not achieved. Before showed that the patient had at 3 months a higher level of BCR-ABL1 control, controlled less than 10% compared to imatinib. Again, it was compared to imatinib, not the highest level of BCR-ABL is obtained with imatinib, but the bosutinib compared to the standard of care initially was in favor of bosutinib when it comes to the BCR-ABL level. Comparison of major molecular response at 12 months also showed a better response with the bosutinib, and I think these parameters are important for all of us. That's why we are mentioning. So you can see here that showing already the efficacy. I will talk about the tolerability, since we are talking about what we say in French, rapport efficacité, the efficacy and toxicity. We can say that here there was no relevant comorbidity or strong contraindication. So it's one of the rare drugs where there is no strong contraindication. We know for those who tried this drug that it's diarrhea that occurs in almost 30%. And we know very well that diarrhea, even if not really life-threatening, but can be a lot annoying as a toxicity. And we have a transit elevation of transaminase in first week or months. So again, these two toxicity for a hemato-oncologist are not really, if I can say it, a big deal if it's not compromising the work. So if we talk about any toxicity, any treatment-related adverse event, we see that the diarrhea is first in 17% of cases. Remember that it's thought 34 in imatinib, but we had never suffered from this. So I think that with bosutinib, you shouldn't. Nausea, it's good. Thrombocytopenia, IST increase, and it's in both, but a lot higher in the bosutinib. Rash, neutropenia, and muscle spasms less. So again, as I told you, you can choose if you want your patient to have less neutropenia, muscles and muscle problems, or if you prefer to him the other toxicity. So it's up to you to discuss with your patient about toxicity. And when it comes to the grade 3-4 adverse event, as you can see, it's 90% and 10% ALAT AZAT increase. It's less in imatinib. Thrombocytopenia, it's 14 versus 6. Lipase increased 10 versus 5. Neutropenia less. So again, all these toxicity are really acceptable, rendering the bosutinib and imatinib the most tolerated TKIs for use in CML. When it comes to cardiovascular and hypertension toxicity, also it shows that the bosutinib compared to imatinib is acceptable. It's almost the same level of hypertension related event and vascular events. We can see that it's similar. And there is no big real difference in peripheral vascular, cerebrovascular, cardiovascular, and cardiac events. The data from the study, the before study, demonstrate that cardiac, vascular, and hypertension adverse event remained low over time versus other adverse event. Why it's important? Because if this toxicity is cumulative, like in some of cardiotoxic chemotherapy, like adriamycin, for example, it will be a problem to give a prolonged treatment. So the absence of aggravation and the absence of accumulation of toxicity lead us to have to be more to deal easiest with this problem. So as you can see, some of these toxicity might last for a long time, and the vascular, for example, not really for a long time. And the summary of the safety in the before first-line trial versus imatinib in chronic myeloid leukemia showed that the rate of completion of treatment is the same in both arms, and the discontinuation is the same in both arms, 18 versus 17, bosu versus imatinib. So you can say that really the toxicity profile, since the continuation or the discontinuation is related to the toxicity. And the discontinuation was due to adverse event bosutinib 13 and imatinib 9. And for suboptimal response, more in imatinib. And for disease progression, more in imatinib arm. And for death, more than imatinib. So there was no death in the bosutinib arm. Patient request, investigator request, it was 1.9 in bosutinib, 4.5. It's, we know in some cases of accumulation of longer treatment by imatinib, we might have some problems. And for last of follow-up, it was the same. Again, the efficacy of bosutinib, which is higher in compared to imatinib, didn't show any complication and didn't show any impact on the quality of life. As you can see in orange, there is no problem, and in green, some problems. So you can see that for the different parameters, mobility, self-care, usual activity, etc., we can see that it is almost the same between the two arms, the bosutinib and the imatinib. If you look at it, you can see that there was no compromise. The quality of life was not compromised. Also, if we compare, and it's an important point for the patient to tell him that you might reach at the 12-month more major molecular response when using bosutinib compared to imatinib. And for example, here we see that it might be even twice higher in the bosutinib arm compared to imatinib. So if we want to conclude, multiple TKIs are recommended for the treatment of patients with CML in first and second line. We have to mention again that the choice of the drug should be based on the efficacy, on the toxicity, and you should discuss it with the patient, on the patient preference, and our region on the accessibility. The before trial, which you knew even for us also, it's really a new drug recently started in our region in Lebanon, the Proteasome versus imatinib in a new patient, Philadelphia chromosome in CML patient chronic phase is efficacious and safe. And if there is no clear recommendation for the second generation, patient-rated factor should be considered when selecting the treatment. And finally, the updated 2020 ELN guidelines include recommendation on appropriate TKI consideration based on TKI contraindication and patient's comorbidities. Again, comorbidities, accessibility, patient choice, efficacy, and toxicity. Thank you very much, and I leave the floor for our chairman.
Thank you, Dr. Fadi, for this updated ELN guideline. This is an educational presentation for the guidelines, the recent guidelines last year of ELN. Now we will continue with the last presentation of the first part, the minimal residual disease. I think, Dr. Samir, we don't have a technical problem now.
We are eagerly awaiting the presentation, Samir.
Yeah.
15 minutes.
Yeah.
And we are on time. Yeah.
All right. I will try to do it in 15 minutes, inshallah.
Yeah.
Thank you very, very much for having me at this time. Really, I would love إنه نتكرر هاي الactivities next time. Today, I will talk about minimal residual disease in multiple myeloma. Next slide, please. Okay, next. I have nothing to disclose. As you see, the myeloma landscape treatment has resulted really in the improvement in overall survival with years. This is actually due to the introduction of novel treatment, the improvement in diagnosis, and in the improvement in prognostication. Next slide, please.
Doctor, you can control them from your side.
I can? Okay. اوكي طيب عم بيتحركوا بسرعة هذول. All right. So that we have the improvement in survival over time, and this comes from our understanding about the importance of achieving complete response as a surrogate marker for improvement in progression-free survival and in overall survival. And here you see the discrepancy between patients achieving complete response versus less than complete response. So that until now, we have CR as an important marker for improvement in overall survival. Now, even in patients who achieved CR, and those patients, if we transplant them, they have yet a better survival than those who do not receive transplant. So that it seems that from this trial that CR is not the only marker for improvement of survival. لأنه حتى هدول المرضى, if we transplant them, still we see an improvement in overall survival. So that what is behind that improvement? It is the minimal residual disease. The first study comes from 2014, which is published in Blood, which tested two methodologies to test minimal residual disease. This is the first trial that tested a multi-parameter flow cytometry and next-generation sequencing in newly diagnosed multiple myeloma. And here, this Pensiri really showed the discrepancy between MRD negative and MRD positive, whether by multi-color flow cytometry or NGS. And after that, the principle of achieving CR plus MRD negativity has been established as a true value for improvement in progression-free survival and overall survival. Now, we know that MRD supersedes the CR as a marker for PFS or OS. We have three now methods, different methods to test MRD. We focus now about the methods to test MRD in bone marrow and to test MRD outside the bone marrow and the new technologies that can incorporate both testing MRD inside and outside the bone marrow. Now, initially, the allele-specific oligonucleotide polymerase chain reaction was established as a first modality to test MRD, and this is now abandoned because you need to have a specific patient allele to test for MRD. After that, multi-parameter flow cytometry, we have an 8-color MFC and 10-color MFC. Then next generation flow cytometry, which is a 10-color flow cytometry with 2 tubes, and next generation sequencing. The testing MRD outside bone marrow has been done by PET scan, CT scan, and MRI. And I will come over each modality and the importance to incorporate both inside and outside modality in a complementary fashion. Now, every technique, whether NGS or NGF, has its own caveats, its pros and cons. For example, the availability of NGS and the NGF, it's widely available, but I don't think in most of the institutions here in the Arab world is applying that modality. We at KHCC, we have an 8-color NGF, but yet we are not routinely doing MRD testing in multiple myeloma. Both modalities, NGS and NGF, are widely available and applicable. The baseline testing is required for NGS, while for NGF is not required. Processing, this is a very important part. Now, you can run an NGS test in fresh or an old sample in paraffin-embedded block, while NGF, you need really a fresh sample. And here comes the problem of doing NGF, where you need really a good sample of bone marrow to run the NGF.
الو ايه مساء الخير وعليكم السلام كيفك شيخنا؟ الحمد لله بعتذر انا كان عندي محاضرة.
Okay. Both techniques are standardized, and these are qualitative techniques, and you can reach the level of sensitivity to 10 to the minus 6, which is really, this is very deep, and the cost is an issue really. NGS cost around $1,500 US, while NGF is $300 US. All right. Is there any difference? Can we use both NGS and NGF interchangeably? Can we get the same results by these two modalities? The answer is yes. This is recently from the part 2 of Cassiopeia trial. I will come into that trial because it's very important. It's 2 parts. The second part was Cassiopeia looking into the molecular testing of multiple myeloma, and they applied NGS and NGF. And recently it was updated, and it showed that whether you use NGS or NGF, yet you can get the same result in regards of progression-free survival and overall survival. So that from this trial, you can use any modality, whether NGS or NGF. And with the advent of new technologies in imaging, whether whole body CT scan or whole body MRI or PET CT scan, we can complementary now test what happens outside the bone marrow in terms of extramedullary disease. we know that testing minimal residual disease by NGS or NGF, you are just tackling the disease in the bone marrow. And we know that the multiple myeloma, it really shows, it manifests in extramedullary disease, and it needs to be evaluated. Now, in each modality have its really its power to test the prognostic value in each patient. The best tested methodology is PET CT scan, which is a functional CT scan. For example, Zamani has shown in a prospective fashion that PET negativity correlates with a better and prolonged progression-free survival and overall survival. While in a large French trial, Imagine trial, which this is the IFM 2009, this is a really large trial, it did show that PET scan correlates with progression-free survival and overall survival. So that PET CT scan is really well correlated with the disease outcome. Now, was that consistent with the recent data on Cassiopeia trial? The answer really is confusing. The Cassiopeia has showed that PET CT scan has a low concordance with the MRD. What that mean? You might get patients with PET negative and yet they have an MRD positive, and the vice versa. You might get a patient with MRD positive and they have a PET negative. The answer for this puzzle is that sometimes patients, they lack an enzyme which convert the fluorinated glucose into an active material which is hexokinase. عشان هيك ممكن يكون هذا المريض is lacking that enzyme so that he turns to be a PET negative. And in that certain point, MRIs showed superiority over PET in this category of patient. Despite that low concordance, the Cassiopeia PET showed that patients achieving MRD negativity and PET negativity, they have really a prolonged progression-free survival and overall survival. And from here, a new principle came, which is the double negativity. I mean, the double negativity by PET scan and by the MRD. And interestingly, if you look into the curves, patients that they have a PET positive disease, they have really a very poor survival. Again, PET positivity, it means that patients, they have an inferior progression-free survival and overall survival. On the other hand, MRI have been tested in several trials, and it correlated in some of trials. There is correlation between MRI negativity and progression-free survival and overall survival. But in a recent trial, French trial, Philippe Moreau, didn't show that MRI has a correlation with PFS and OS. And the reason behind that, sometimes focal lesions, focal extramedullary disease, lags behind the MRD negativity. I mean, in other words, that some patients, they may achieve MRD negativity, and they will take time to focal lesions to disappear. So that there is a caveat in the use of the MRI in terms of assessing the complementary effect on progression-free survival and overall survival with MRD. وغير هيك إنه كمان there is a lot of trials that didn't show that correlation. Okay, just to summarize that, what we have from PET, what we have from the MRI. Now we learned that the PET CT scan can detect patients with high risk for progression. It has a prognostic impact on multiple myeloma. it has a complementary effect with MRD negativity, and again, it has an important role in determining the prognosis once they have a PET positivity after transplantation. On the other hand, MRI is superior to PET scan to detect whether the disease is diffuse or focal, and it showed an early changes of the disease on bone and bone marrow, and it might be more sensitive than PET scan in detecting bone marrow activity. The Eln guideline didn't incorporate MRI in the definition of MRD negativity. The guideline I will show you later is dependent on PET-CT scan according to the large published data and the lessons we've learned from the trials I've shown to you. This is a very interesting meta-analysis, recent meta-analysis. Actually, they took an 86 publication and they looked into the impact of minimal residual disease in different disease categories of myeloma patients. And here we see the very good correlation of MRD negativity in transplant-eligible, newly diagnosed multiple myeloma, and the same in transplant-ineligible multiple myeloma and in relapse refractory multiple myeloma. Not only that, patients with low risk and high risk MRD negativity did show discrepancy in terms of PFS and OS in low and high risk. So that from what I've mentioned before and from this large meta-analysis, MRD should be the strongest endpoint that discriminate between multiple myeloma patients with transplant eligible or ineligible or relapse refractory, whether they have a high or low risk. And from that, I will dive into the literature looking whether MRD really made changes according to treatment protocol. For example, this French trial, IFM 2009, looked into VRD and consolidation followed by maintenance lenalidomide versus VRD with transplantation in an attempt to answer what is the importance of doing transplant in newly diagnosed multiple myeloma. And the result came in favor of doing transplant. And the result also have shown a very nice finding that achieving MRD negativity, regardless of the way you have achieved MRD, with or without transplant, they have the same progression-free survival. This is the principle we learned from this trial. No matter how you achieve MRD, you will get the same PFS and OS results. And the second similar European trial, this is MNO 2, Hoven 95, tested the same question. What is the importance of doing transplant in newly diagnosed myeloma? Their VCD versus transplant or VMP as induction treatment, followed by VRD consolidation and lenalidomide maintenance. And the result was positive again for the arm that received transplantation. Recently, this is a few weeks ago, the results of the trial showed that patients achieving again MRD negativity, they have a high PFS and OS, regardless of the way you have achieved that, whether transplanted or not. So that we're learning principles. We need to have an MRD negative. We need to have a double negative test, which is MRD and PET negative. And the second or the third principle is whatever the way you have achieved it, you will get the result of benefit from that MRD negativity. And the most important trial, which is the Cassiopeia trial, and from this trial, I have learned something, which is how to deepen the response and how to achieve more minimal residual disease. And this trial, daratumumab was incorporated into VTD in the induction and consolidation arm with transplantation, followed by daratumumab maintenance. This trial was two parts. First part tested the VTD, Dara VTD regimen in a background of testing the minimal residual disease by NGF, NGS, and PET scan. The part two tested the value of daratumumab maintenance. And I have showed you the part two, which is the Cassiopeia PET, and the importance of achieving PET negativity will principally double negativity with PET scan. In the Cassiopeia trial, the addition of daratumumab reflected on a better and deeper response compared to VTD, with almost 64% achieving MRD negativity with daratumumab versus VTD alone without daratumumab. So that daratumumab deepens the response. You might the chance of getting a higher chance of MRD is higher with daratumumab. Again, that was reflected on progression-free survival and overall survival. When you look into the value of MRD on progression-free survival, the curve is really very clear that patients who have daratumumab and MRD negative, you're seeing a straight line. This means that really you get a disease relapse with that. An interesting similar trial, which is Maya trial. This is a daratumumab in non-transplant eligible newly diagnosed multiple myeloma, incorporated with a backbone of lenalidomide and dexamethasone. This trial really showed something as a fourth principle in MRD journey, which is the sustainability of MRD. Look into the left top figure here. Patients achieving one test negative with DRD was in close to 29% compared to 9% with RD alone. And this was reflected with a better progression-free survival. Now, in the bottom left figure, patients who have a sustained MRD defined by another MRD test in a 12 months time, 11% on DRD versus 2% on RD. يعني sustainability of MRD with RD, you barely will see an MRD that maintains a 1 year with RD. But you have an 11% with DRD that may sustain really more than 1 year. And again, the sustainability was reflected on a better progression-free survival with 66.3% with sustained DRD versus 52 with one reading of MRD negativity. The fifth principle, if you get one result of MRD negativity, this will reflect positively on على progression-free survival and overall survival. يعني ما نقدرش نستهين حتى لو في one test of MRD negativity حتى لو إنه turn positive after that. In the Alcyon trial, this is a transplant eligible elderly patient. Again, daratumumab, when was added to VMB, it was really reflecting a positively on progression-free survival. Again, there is something very interesting from this trial, that achieving a sustained MRD more than 12 months in 14% of patients achieving daratumumab and VMB was reflected on their progression-free survival. Just the sustainability of MRD. The second interesting thing in this curve, now those who have an MRD positive disease compared to MRD positive with VMB alone, patients with DVMB they have a better progression-free survival, as if daratumumab is changing the behavior of multiple myeloma. مع العلم الاثنين they have MRD positivity, بس yet الناس اللي أخذوا daratumumab they have a better progression-free survival. And in relapse refractory multiple myeloma, again, daratumumab in Pollux and Castor trial was reflected the same with a better progression-free survival in patients with MRD negativity. And again, there's a very nice split between MRD positive and MRD positive for patients receiving or not receiving daratumumab, just confirming the principle or the concept of that daratumumab might change the microenvironment of the bone marrow. Now, in 2016, the International Myeloma Working Group modified the response criteria, and they incorporated minimal residual disease in their response. It's not just stringent CR or CR or VGPR. Now there is 4 categories of minimal residual disease. The first category is sustained MRD. The second one is flow negative MRD. The third one is the NGS negative MRD. وما في different according to the Cassiopeia trial. There's no difference between whether you test it by NGS or NGF. But the deeper you get it, I mean to the 10 to the power minus 6 better than 10 to the power 5. The fourth one is the double negative. I mean having MRD negative and PET negative. So that these are the 4 categories now in the International Myeloma Working Group response criteria. There is a pitfalls for MRD negativity. أولاً اللي هي quality of the bone marrow testing. احنا بنعرف إنه البون marrow in multiple myeloma it has a patchy infiltration, so that your needle might hit the group of normal plasma cells. عشان هيك تطلع ال MRD negative. Second thing is hemodilution. Again, you might get a lower percentage of abnormal plasma cells with hemodilution, so that you might get a false negative MRD test. Second point is the transient MRD negativity. As I've shown you, the sustainability of MRD is more important than getting a one reading. But again, having a one reading means that you really get a deep response with your treatment. A third and very nice and important, أنا ما وجدتكمش سلايد عليها بصراحة، اللي هي benign MRD. From the French trial, كان في small group of patients. This is very nice, by the way. In the IFM 2009, a small group of patients who achieved MRD negative, and they have a phenotypic feature of MGUS, monoclonal gammopathy of undetermined significance. هدول كانوا the 12 years progression-free survival was 90%. This is what we call operational cure, so that we might define some patients with multiple myeloma that might be operationally cured with treatment, and those patients are MRD negative and they have the phenotypic feature of MGUS. الشغله الثانيه انه sometimes with your treatment بصير في عندنا immune reconstitution, so that a new population of plasma cells will regenerate سواء بعد bone marrow transplant or after daratumumab, especially when it hits the CD38. And I will come to that important point, hitting CD38 and the importance of immune reconstitution. So that you might get false results with the MRD. And finally, the presence of extramedullary disease. So that MRD by NGS or NGF alone is not enough. You need to complement that with PET scan or MRI. CT scan الآن was not standardized test for complementary effect with the MRD. I will finish with this slide with more questions than answers. And في عنا a lot of questions to be answered in MRD. but it is the future. It will finally be the endpoint. أكيد راح يكون هذا the endpoint in every clinical trial in multiple myeloma. شغلة هلا تانية عم it has been developing now, which is the liquid biopsy. So I'm testing circulating tumor DNA أو circulating tumor cells. للآن ما في good correlation between liquid biopsy and bone marrow MRD. But in the future, there is a concordance like in 50 to 60% of patients. In the future, we might get a technology that we might not need to do a bone marrow biopsy in these patients. PET MRI, this is احنا حكينا انه ال MRI is a good tool, PET scan is a good tool. What about if we combine both PET MRI, not PET CT scan, or the immunopET? There's a new technologies adding daratumumab with PET scan. لأنه daratumumab, once if you label it with an immune fluorescent or immunoactive substance, it will attach to the plasma cell. You may get a functional imaging for a plasma cell. This is the immunopET. And finally, we do not have a guideline how to incorporate MRD in decision making regarding the treatment, whether to stop or switch treatment or change to another line. But there is an ongoing trial incorporating MRD negativity in decision making, therapeutic decision making. And by this, and I conclude my talk. Thank you for your attention. Thank you again for giving me this opportunity.
Thank you, Dr. Samir, for this presentation on MRD. Now we have a few minutes for panel discussions. And the panel discussion, we have two discussants. We have Dr. Sahwan Tawfiq. He is a hematologist, oncologist at Sulaimania KRG in Iraq. And Dr. Fawaz Dairawan is consultant hematologist oncology at Shifa Hospital and St. Louis Hospital in Syria. So we have the panelists, we have the audience, and we have 10 minutes, I think. We have 10 minutes, I think. We will try 10 minutes, not more, discussion. So the question is, the floor is open for question, but we have some question already here. The first one from Dr. Fadi Alias. Is there any TFR studies with bosutinib?
So I think
this question is for Dr. Fadi Farhat, I think, CML. Okay.
Yes, indeed. No, there is no data on the treatment-free. There is no data. The only data, I think, it's
no data on TFR bosutinib, as you said. There are some few recent studies, particularly from America, a few patients, and particularly from MD Anderson, where patients stopped bosutinib or Ponatinib or beyond the nilotinib and the dasatinib. And the profile for these few patients is like the profile for dasatinib and nilotinib for TFR. We have to reach at least M4, M45 for a while to be safe, because some patients stop after MR45 and others stop because of toxicity and obtain the same profile of the other second generation. So there is no study, as Dr. Farhat said, but some reports are showing us that we will have the same profile if we stop bosutinib in the future. The other question from anonymous attendee, it is for MRD negativity for Dr. Samir. How frequent you do PET for your myeloma patient? It's also a question for Jean Sheikh. Is it specific? Yes.
Dr. Ahmad, please, if you allow, the panelists should be involved in the discussion.
Okay.
And to give their opinion and even to manage questions.
Okay.
You may supervise and help.
Okay. يعني the panelist will ask.
They can ask and they can give their opinion. As chairman, you can ask Dr. Chwan, what about his opinion on TFR, for example?
Okay, but okay.
Well, may I ask Dr. Fadi?
How frequent you do PET for multiple myeloma? Is it specific? Do you use it to confirm CR for our panelists and the presenters?
Thank you for the question. We do it initially at the diagnosis. You can do either you can do PET CT scan, or you can do whole spine and pelvic MRI. And after autologous stem cell transplantation, if the patient achieves CR, you can do PET scan. And in patients after autologous stem cell transplant, if they achieve CR, you do PET CT scan.
But the question is, frequently do you use PET scan? For example, you are treating the patient with multiple myeloma for a year. How frequent do you do your PET scan? After CR and beyond?
The diagnosis after CR بعد الترانسبلانت.
Okay. Do you do PET scan before transplant? For example, you are treating the patient for 6 months, for 5-6 months. You do PET scan before?
No. You do not do it before transplant. No.
Okay, let's move. Then what's the cutoff?
But the right, Dr. Jean Sheikh, please, Mr. the President, Jean, do you think that now we are talking about MRD negativity and the value of MRD negativity before transplant? You say you talked about IFM 009 and Alcyon, and the patient who are MRD negative transplanted better than patient who were transplanted MRD positive. What do you think, Jean? Is it important to do to have a kind of negativity, or to try to have negativity by test, to prove by test, including PET scan or before transplant? Jean.
If PET scan is available in your center, obviously yes, but you need a baseline PET CT scan evaluation as initial workup. So you need initially PET CT scan, otherwise it's only, as my colleague mentioned before, with the International Multiple Myeloma Working Group, we cannot recommend the PET CT the only test for MRD. Okay. We need a baseline PET CT, and for specifically for the extramedullary disease, yes. Basically, post-transplant, yes, to show if we have any active disease for those patients who achieved a CR. We can see if we have any extramedullary disease, active disease, maybe to add the biphosphonate, or maybe to make some consolidation post-transplant. However, for the patient, elderly, non-fit, non-eligible to transplant, I think we can preserve the PET CT scan for those patients, and no need, if no changes in the treatment protocols. It's our recommendation.
Okay.
The next question, Dr.
I can't.
Yes. Good evening, everybody. I am so happy to be you. Yes, and thank you, my dear panelist and the speaker. I just want to ask Dr. Fadi, can you give us a little bit more details regarding the immune PET, please?
The immune fit?
Immune PET.
Immune PET. The question is for Dr. Samir or for Dr.
This is the question for Dr. Samir, the immune PET. for MRD negativity, no?
Yes.
Yes.
Dr. Samir.
Here, basically, in a simple way, احنا في البيت سكان بنعطي المريض اف دي جي اللي هو الفلورينيتد ديوكسي جلوكوز. هلا بدل ما تعطي اف دي جي تعطي فلورينيتد داراتيوموماب. عرفتي؟ والداراتيوموماب will stick to the CD38. عرفتي؟
Yes.
Then you will image multiple myeloma whenever it is in the body. هي فكرة الاميون.
And it is available.
لا, it's still in the clinical trial.
In clinical
Still
trial.
under investigation.
Yes.
Okay.
I would like
Nice to know that. Yes.
Yes,
Dr. Schwan.
Yes, thank you. I would like to ask you, Dr. Fadi, about your experience with Ponatinib and diarrhea. Do you start with low dose and increase it gradually? For example, you start with 200 or 300 milligrams and then increase to 500, or start with 500?
Indeed, we start with I usually start with the indicated dose, and then after I decrease. In some rarely case, if we have really some old patient, we might decrease as we do in chemotherapy for 25 or 30% of the dose. But as I told you, Ponatinib is new even in our region, so it's not. We don't have a lot of experience like Imatinib or Nilotinib. But I presume, and this question is always asked. I try to go as per protocol. You should start as per protocol.
You can reduce according. You can reduce if diarrhea is high.
Later on, but he's asking initially.
But
initially, yes.
initially لا هو لانه بسأل اذا صارت دايريا مش هيك ولا بتخاف ما يصير دايريا و you reduce the dose
from the start. Some physicians are
you have to start by مثل ما قال فادي by the dose اكيد the adequate dose.
Okay, I agree with you. Thank you.
في عندنا question هون. What is the cutoff age for auto transplant? Probably Dr. Jean Sheikh could answer this question, Fadi.
Thank you, Ahmed. For multiple myeloma patients, there is no cutoff based on the age only. Age and comorbidity, obviously, if the patient 75 years old and he is fit, there is no contraindication to do transplant. We did several studies, not randomized, but observational study. Less than 70 and above 70, there is no difference. We can maybe go with low dose intensity with melphalan 140 compared to 200, well tolerated maybe for the elderly patient.
Okay.
We did some transplant above 75, but it depends from the patient decision and the severity of the disease. Obviously, as we mentioned, we need a continuous tolerable treatment with or without a transplant, and to balance between the efficacy, the MRD, and the tolerance of this new drugs, DARA, or maybe proteasome inhibitor every 2 weeks, or maybe lenalidomide alone. And maybe I can jump for the next question. Duration of maintenance is until progression. We don't have any limitation for the duration of the maintenance therapy. The French study...
duration until death from other cause than multiple myeloma.
Maybe, but the actual recommendation is still progression.
Yes, okay. There is no, the problem of transplant is, of auto transplant in multiple myeloma is not the age, it's comorbidities.
Exactly, I want also to stress, we are dealing with the physiologic the age rather than the chronologic age.
Yes, sometimes you have 50 with many comorbidities and 70, 75 without comorbidities, and you succeed with the second one more than the first one.
Exactly.
Other questions? Oh, there is a big question here, probably to Dr. Samir. What is the difference between NGS and NGF? Between next generation flow and next generation sequencing? The difference.
Basically and simply الفلو سايتومتري. خليني اول شيء احكي شو الفلو بعدين بحكي شو شو معنى نكست جنريشن. هلا الفلو سايتومتري simply you get an antibody, okay, and that binds to a specific receptor on the cell, like مثلا CD38, 138, CD56. This is on the surface of the cell, so that it is an antibody that has a fluorescence and it attaches to the surface of the antibody or the cytoplasm. Now, this is the flow cytometry. هلا الفلو سايتومتري مر في مراحل في تطور. بلش اول شيء the simple flow cytometry، بعدين طلع في عندنا اللي هو multi color flow cytometry اللي هم صاروا ممكن يحطوا 8 antibodies with different colors that attaches to different receptors on the plasma cell. بعدين طلع في عندنا اللي هو third generation which is the next generation flow cytometry that you can use 10 colors of antibodies, so that flow cytometry is antibody on the surface. Now, next generation sequencing, you take the DNA from the plasma cell and you do sequencing. You amplify the DNA and you test the DNA. It's not the receptor. Simply, this is the difference.
يعني to be practical.
Can I add?
ما هي to be practical. لأنه يمكن حتقولوا اللي حقوله.
Maybe I don't know.
شايف إنه
Go ahead, John. Go ahead.
قوي قلبك جون.
حتى أحمد عم بيعرف شو بدنا نحكي يعني قبل ما نحكي. لا, in comparison with the AML patient, the NGS, we don't have any targeted therapy for multiple myeloma now, like IDH1, IDH2, the XMX, etc. So in multiple myeloma, if we don't have a targeted therapy for the NGS testing, we should preserve it only for clinical trial, and maybe for the future is not recommended for all the patients with multiple myeloma for now. Maybe we can make a cytogenetic FISH to define the standard risk, intermediate risk, and high risk patient. Based on this, we can tailor our treatment protocols to define which patient need the triplet, quadruplet, daratumumab as first line, or maybe as consolidation combined with proteasome inhibitors and IMiD, the duration of the treatment, and maybe the maintenance therapy later on. But for now, we cannot recommend NGS for all the patients with multiple myeloma.
أكيد NGF is more practical because this is according to Euroflow something أكيد asking for expertise, but we can arrive to a sensitivity at 10⁻⁵, sometimes to 10⁻⁶, and we are using in this kind the 8 or 10 color flows with U-tubes. This is easier than NGS. We have to search the nucleotide and to do qPCR, etc., and it is more expensive. But probably when we compare some recent report comparing NGS to NGF, and NGS is not will be the gold standard for probably in the future for
Samir mentioned, Ahmad, I'm sorry, but Samir nicely presented the data. So we have some normal clone as the MDS patient, like the CHIP, the CHIP, clonal hematopoiesis with especially in elderly patient with multiple myeloma. And we don't know the significance actually for this clonal clone. And if we don't have any modification in the treatment, we cannot take into consideration these clones.
But when you orient your NGS for the oligonucleotide of immunoglobulin, you have a specific detection of the disease independently of the secondary disease associated to the multiple myeloma or occurring during the follow-up of multiple myeloma. We have an anonymous attendee. Does DARA affect negatively the BMT outcome? Jean?
Obviously, no. Obviously, no. We are moving rapidly to put the new R-CHOP in the multiple myeloma using daratumumab as first line with VRD. Is a new quadruplet for young patient. DARA as first line, and we problem, as you know, is to define the ABO group before using daratumumab.
The phenotype.
Yes, for the transfusion only, but
and probably, most probably, if you see the DARA VRD versus VRD, the MRD negativity is higher with DARA VRD with quadruplet versus triplet versus VRD, as you see in the Griffin study, for example. We have another question, maintenance. You answered. Anonymous attendee, do you use ASA or Clexane during induction? It is probably for كمان Jean إذا بدك أو Jean.
ما فهمت كتير السؤال صراحة.
سؤال, if you use ASA or Clexane during induction, probably we are talking about Fraxiparin, about enoxaparin. Probably this question is oriented on the usage prophylactically of anticoagulant during induction therapy, first-line therapy of multiple myeloma. What do you use? If you use, for example, triplet or quadruplet to prevent thrombosis. Probably this is the question. This is the question.
Anyway, it depends from the risk of thrombosis in this patient. When we use Revlimid for patient fit without any comorbidities, the only recommended dose is low dose aspirin, obviously, with Valtrex and Bactrim. With the patient elderly with previous history of thrombosis, phlebitis, etc., already the patient present to us with some anticoagulation treatment, so we should continue monitor better and longer those patients, but no indication to add any anti-aggregant or anticoagulant treatment for those patients, either for Revlimid or Velcade therapy.
That's a question, I think it is a question economical. In the low-income countries, what are the most information, the minimum information, and investigations needed to declare cure? This is an amazing question. What is in low-income countries the most informative minimum investigations needed to declare cure?
Very practical one.
And in multiple myeloma we are not cured. In CML we are functionally cured, but إنه عم يطلب المينيمم of investigation تقول إنه this multiple myeloma or CML is cured. First of all, يعني it's difficult أكيد مش هيك question، بس إنه قصده إنه شو المينيمم ليقول له تريح المريض وتقول له to tell that you are on a good shape. شو المينيمم؟
It's based to build our inverse pyramid based on the complete response with the immunofixation, followed by the FISH study and cytogenetic studies, followed by the MRD and the PET-CT scan. We mentioned in our presentation previously about the more deeper we have the MRD, less the relapse rate is and the duration of the response is high.
Is to assure the minimum of tests for MRD like flow, like PET or MRI, or in CML أكيد the molecular test.
أحمد هو ال sustainability of the results يعني مش بس one test is important.
Yes, which is important is the sustainable system in multiple myeloma أكيد وإن CML and أكيد MRD negativity sustained led to higher PFS than non-sustained MRD like in مثلا Alcyon over 12 months or in the IFM. Okay.
أحمد خلي دكتور سمير to express his idea to continue.
من ناحيه كوست افكتيف ارخص تيست عارف كيف ممكن تعمله to assure the cure او operational cure in multiple myeloma انه shaking hands with your patients after 10 years of treatment.
Very nice.
اكيد بس انه you have to do for this patient regularly some tests ما يكونوا غاليين كثير قصده ويكونوا cost effective انه شو هن انه
احمد ما فيش غاليين ما في I don't think either you do
you know if you can allow me we have one time بعد الكورونا to sit and to establish a consortium for our region يعني كيف اليورو فلو كيف الام جي اس الشغلات نحن وي كان اذا قعدنا وعملنا هارمونيزيشن للمنطقه بصير التست ينعمل بمحلات معينه مع اكسبيرينس معينه وارخص and it will be more cost effective.
بس اذا ممكن اضيف شغله واحده بعد اذنك مساله الانتي كواجوليشن انا just I agree with Jean. احنا في الانتي كواجوليشن we customize patients according to the risk of thromboembolism سواء المرضى بياخذ ثاليدومايد او الليلادومايد هذول they need anticoagulation according to the risk وفي عندنا two models to assess the risk of VTE in multiple myeloma patients. هلا المرضى اللي عندهم low risk for VTE aspirin is enough. ناس with high risk of VTE whether you go to enoxaparin full dose أو recently published in the guideline اللي هو الابيكسابان you can give it as a prophylaxis for VTE.
Yes.
I believe we have to look at this question in a careful way because not only the cost is the direct cost. As we all know that we have a direct cost as indirect. We are dealing with that could be if properly diagnosed, if properly managed, it could be curable. We can properly diagnose to what level we have a cure. So looking at the cost, we have to look at a wide view or a wide window to assess not only the direct cost that looks to be great, but if we assess both direct and indirect cost to reach a proper diagnosis and a proper giving our patient a proper treatment and the proper assessment for his response, so we can get a cost-wise decision to accurately diagnose the patient cure or not. So we have to not only address or assess the direct cost only, but also the indirect cost should be looked carefully at this point.
Exactly.
Okay, so Dr. Fadi, we can probably move to the second part. كمان the second part هتفتح discussion كتير مثل أول part. So the first presenter is Dr. Khalid Ibrahim. He is a clinical associate professor of hematology oncology at Beirut Arab University, and he will talk about on primary myelofibrosis 2021 update on diagnosis, risk stratification, and management. Khalid, we see you, so we are happy to hear you. About 30 minutes.
Good evening. Good evening. Thank you very much. Thank you, Ahmed. Thank you. Thank you, Fadi, for inviting me. That's very good. For the slides to open.
شو هيدا تعبنا.
والله بيني وبينك أنا خفت كمان يعني. Okay, Vanessa, please let's open it. Thank you very much. Next slide. Next slide. Okay, thanks. Thanks very much. So it's, you know, as Ahmed said, it's a quite complicated issue. Myelofibrosis is a very unique disease with many questions and less answers that we have. Now, what I'm gonna do is just to have a review on myelofibrosis. I will touch on the approved drugs that we're using. I will not discuss the issue of transplant. I will leave it for the transplanters. And I understand Ahmed will discuss this. And I will not discuss also the issue of splenectomy in myelofibrosis. I think these are very, very, you know, controversial and tricky issues. Now, myelofibrosis and PV and essential thrombocythemia are a group of heterogeneous disorders of the hematopoietic stem system known collectively as MPNs. Now, the prevalence of in the United States is approximately 13,000 per year for MF versus around 150,000 for PV. Now, in general, MPNs are relatively rare. And among this rarity, myelofibrosis stands. Next slide, please. Next slide. Okay. Now, MPNs are classified based on BCR-ABL1 status. And in the WHO 2016, myeloproliferative neoplasms are divided into big groups. The first one is the BCR-ABL positive, which is CML, and the BCR-ABL negative, which is MF, PV, essential thrombocythemia, as well as other MPNs. Similar to PV and ET, MF is considered a BCR-ABL negative classic MPN. Next slide, please. Now, myelofibrosis, the cause, the disease initiating genetic mutation is unknown. The causative agents also are not being identified. 0.22 to 0.99 per 100,000 persons in the United States. The median age is 67 years. The survival varies from 27 months to 135 months according to the risk factors, and we're gonna discuss it in quite detail. Now, the survival is dismal whenever you have a transformation to AML, and the survival is quite short, is less than 3 months. And now the transformation to AML occurs in up to 23% of patients within the first decade. Next slide, please. Now, the disease burden in myelofibrosis is very important. What are these patients suffering from? Splenomegaly is the most important. Also anemia, cytopenia, and let's not forget about the constitutional symptoms. These are annoying symptoms, and they bring patients usually to our attention. Next slide, please. What about the JAK2 V617F mutation? In general, 50% of the primary myelofibrosis, they have this mutation, which means we have 50% not having this. Let's not forget about other mutations like the CARD and the PMN that we'll discuss in a couple of slides. Next slide, please. The disease course and complication of MF is important to look at. The early PMF, we have short-term problems, usually vascular events, but the lead time typically more than a decade. On the other hand, the overt PMF, whether it's post-ET or post-EPV or MF, primary MF, we have progressive constitutional symptoms that needs to be treated for sure and controlled, progressive organomegaly, and progressive cytopenia. Now, this leads to the decrease of quality of life and a progressive immobility, morbidity. So your patient can live as an early PMF in a decent life. Whenever we have the overt PMF, everything bad starts. And now, let's not forget that in overt PMF, the leukemic transformation is there, and this leads to a premature death. Now, 1 decade for the early PMF, time is around maximum 7 years to have all the complication whenever we have the overt PMF. Next slide, please. Next slide. Yeah, it's an important slide. I wanted just to put it and to mention that there is an entity called early pre-fibrotic primary myelofibrosis versus essential thrombocythemia. This is an important issue. This is an important issue because if you look at the right side of the slide, you will see that there is a big difference between the transformation to overt myelofibrosis between both entities. How would you differentiate those two? Well, the morphologist and the hematopathologist should help us. You will see mature platelet syndrome, megakaryocytes, and essential thrombocytopenia. You will see abnormal megakaryocytes in the pre-fibrotic primary myelofibrosis. You will see cluster of megakaryocytes in ET. On the other hand, you will see clones and primary myelofibrosis and other considerations that should be taken. So we should always, whenever we are approaching patients with this differential diagnosis, I think the role of the hematopathologist and the pathologist is very important. Next slide, please. So that's why this slide on the right, on the left side, the pre-fibrotic myelofibrosis can mimic essential thrombocythemia, and the major presentations are bleeding and thrombosis. On the other hand, with time, we will have a progression toward an overt myelofibrosis with all the symptoms of myelofibrosis. Next slide, please. Next slide. That's the pain. That's the real pain in patients with myelofibrosis. Splenomegaly, that is always progressive. Well, it can be progressive fastly according to the risks that we have, and it can take time. But at diagnosis, what we know statistically that around 21% of the patients, they have palpable splenomegaly, which means a spleen more than 10 centimeters. And look at the right side. In 1 year after diagnosis, it doubles. It's 46% having the same size of the spleen, which means it's very important to identify our patients, to put them on the right strategy for treatment, maybe for observation in some patients, but in general, in a strategy for treatment. Next slide, please. And let's not forget that other than splenomegaly, we should not forget the problem of fatigue. I mean, all the hematologists, oncologists in the audience, they saw Sorry. So I had change in the electricity. So are you hearing me?
Yes, doctor.
Okay. So the other symptoms that are very important are fatigue, insomnia, as well as, you know, what is attributed to splenomegaly, like early satiety and abdominal discomfort. Next slide, please. Next slide. Okay. And this leads to impaired quality of life. 45% of them, they have impaired activity. 41% of the patient, they report overall impairment at work. They do not work, they cannot work properly. And 34%, around 40% even, of patients with MF, they report that disease cause emotional hardships. Next slide. A very informative slide. يعني showing that constitution
Dr. Khalid was disconnected.
We don't hear you.
So constitutional symptoms are prognostic for shortened survival. If you look at this slide, it's a very nice and informative slide. At diagnosis, constitutional symptoms, they decrease our chance 2 times, or they increase the risk of death in two times, whereas if you go throughout the course of the disease, it's doubling, it's 4 times. So until now, we understand that the myelofibrosis is the disease that causes a lot of problems that should be approached properly by us. Next slide. What is the prognosis? What we have? Slide, please. Next slide. Yeah, next slide. Okay, that's it. So what we have, how would we stratify our patient? Well, a very important system is the prognostic scoring system that was established in 2009, the IPSS, 4 adverse prognostic factors for primary MF. That includes age more than 65, constitutional symptoms, hemoglobin less than 10, a white BC more than 25, and blood blast more than 1%. But what is this IPSS? The IPSS, and this is an important thing, it identifies 5 prognostic factors, yes, but this IPSS predicts survival at the time of diagnosis. يعني أول ما نحط diagnosis, we can use the IPSS. Why? Because we will see that we have other systems that will stratify our patient during the course of the disease. Next slide, please. Now, if we look at the pure IPSS risk and survival, if we look at the risk category, low means that 0 from all these 5, with a median survival, which is fairly good, around 11.5 years, and it comprises only 22% of the population. Whereas if we take the intermediate 1 and intermediate 2, which is 1 and 2 risk factors, look at the survival, how it drastically drops from 11.3 to 7.9 to 4, even between 1 and 2 risk factors. And if you look at the percentage, that's where we start to swim in the real life in MF. If you look at the intermediate 1, 2, and the high, which is more than 3, it results in 80% of the patients, which means the majority of the patients that we see are intermediate 1 and 2, and some of them are high, luckily. Let's next slide. Now, we have a lot of things to discuss here. I'm not gonna discuss because it will take too much time, because many scoring systems were developed. As much as we understand more about the disease, about the clinical manifestation and manifestations and the significance of some of them, as much as we incorporated in all the hematology, hematological malignancy, we started to incorporate cytogenetics and genetic approaches. It's obvious that we're not gonna stay just on these 5 points. Now, next slide. Next slide. Okay, just a minute. Slide now, please. Okay. So what is this? What is these systems? So we know IPSS, and then a DIPSS, which is a dynamic one, which means what? That you can incorporate this during the course of the disease. And then the DIPSS plus, which took into consideration platelets, number of transfusions, karyotypes, also a scoring system. So it's not only IPSS, so now we are adding many others. And then the MIPSS 70 and 70 plus version 20, that is based on what? On what we had in the IPSS, but plus what? The mutations, the bad mutations, like the ASXL1, IDH1, IDH2, and others. And the last one, and not least, is the genetic, which is GPISS. So we have a lot of systems. Now it's perplexing, but what is very important here? And we are lucky now to have transplanters among us, and this is something that I will not wait for the question. I will ask the question for the transplanters: how much the mutations and how much those new systems are pertinent for selection of the patient for transplantation. Next slide, please. Okay. So what are the goals of therapy in MF? Cure the disease, prolonging survival, and as a primary goals, and secondary goals is to reduce disease burden and subsequently to ameliorate the quality of life. Next slide, please. Next slide. Okay. So how would we approach our patients? As I showed you in one slide, that patients with low risk, with the risk of 0, they live around 11 years. So would you transplant these people? Of course not. But whenever we approach those patients, we approach them with needs, what they do need, why they are seeing us, what are the problems that they are suffering from. So whenever you have anemia, you have a lot of things to use, like steroids, danazole, thalidomide, lenalidomide. It's controversial to use erythropoietin because some studies did show that using erythropoietin sometimes can cause an increase in the splenic size, and it can, at the end of the day, of course, cause more cytopenias as well as worsening of the anemia. Now, in symptomatic splenomegaly, ruxolitinib and fedratinib both are approved in this situation, as well, of course, as hydroxyurea, because hydroxyurea is one of the drugs that we should not forget in MF. Constitutional symptoms, both JAK2 inhibitors, as well as steroids. Sometimes, if we have extramedullary hematopoiesis, radiation therapy is indicated. In a very small contingent of patients, interferon in hyperproliferative early disease can be used. If we have an increased risk of thrombosis, low-dose aspirin. And in accelerated blastic phase, it's a big question. Some studies are looking at the hypomethylating agents. And for improved survival, definitely allo BMT if the patient is fit, if the patient can tolerate the allo BMT. And this is a big question. I didn't want to discuss it. I will leave it maybe for the discussion later on. Now, for low risk observation or JAK, next slide, please. Next slide, please. So, for low risk patients, observation or JAK inhibitors, according to symptoms. For intermediate 1 risk, JAK inhibitor and or allo. In intermediate 2 risk, allo or JAK inhibitor, and for high risk, allo, then allo if we can do it, or JAK inhibitor and or anemia treatment. Next slide, please. Okay, so let's go specifically to ruxolitinib. What is ruxolitinib? You know that JAK-STAT signaling controls cellular differentiation, growth, development, and survival. Now, the mutation in JAK2 leads to overactivation in the pathway and abnormal production of blood cells. Subsequently, whenever we use Jakavi or ruxolitinib, it blocks the abnormal stimulation of the JAK-STAT pathway, and subsequently, it restores regulation of survival and proliferation. Next slide, please. Now, the phase 3 studies that we're going to discuss support that Jakavi as an option to address some unmet needs. What are these unmet needs? The reduction in risk of death, and we'll see that controlling the disease and controlling sometimes spleen, splenic size, and many other can lead to the reduction in risk of death. A reduction in spleen volume, which is very important, annoying, and also it has an impact on survival. A reduction in symptoms and improvement in quality of life. Next slide, please. Now, the Asthma Guidelines recommend Jakavi therapy in appropriate MF patients across all risk groups. So you take all risk groups, but not all risk groups deserve treatment. So speaking of patients with low risk, if they are asymptomatic, we should observe. Otherwise, we go. Now, next slide, as it is. Next slide, please. No. ترجع slide لورا بس بعد لورا. Okay, so let me state how the Asthma Guidelines are built. For high and intermediate 2 risk, if eligible for allo, SCT is the first line recommendation. If ineligible, Jakavi or conventional treatments should be considered. We're talking about high and intermediate 2 risk. Let me tell you, whenever you're talking about, usually it's the IPSS. Now, low and intermediate 1 risk, symptomatic patients should be treated with Jakavi or conventional treatment. We're not talking about transplant here. If asymptomatic, watchful in waiting is recommended. Now, what about the NCCN guidelines? Little bit different. For high intermediate to risk, if eligible, allo, in the first line recommendation, if ineligible for allo, treatment decisions are based on platelet counts. So in ESMO, we're not talking about whenever we are using Relapse, we're not stratifying patients according to platelets, whether in the NCCN guidelines, more than 50,000 platelets, Jakavi or clinical trial, less than 50,000 platelets clinical trial. Now for low and intermediate one risk, treatment is based on symptom burden. Symptomatic Jakavi, asymptomatic observation, clinical trials, or other therapy. Next slide, please. What is the evidence? What are the evidence that we have? Actually, we have two important phase 3 trials, Comfort 1 and Comfort 2, where ruxolitinib is being used for patients with intermediate 2 risk and high risk. What is the difference between both trials? Well, we're going to discuss them in details, but let me give you a grosso modo. Well, the spleen volume was the most important, and the target was to reduce the spleen volume more than 35%. In the Comfort 1, the target was at week 24, Ruxo versus placebo. On the other hand, for Comfort 2, the outcome was assessed on the week 48, but the design is Ruxo versus what? Here it's placebo, and the Comfort 2 is the best available therapy. So philosophically speaking, the drug is being challenged against the placebo first, and then challenged against treatment. Of course, the data were positive in favor of ruxolitinib, and now we're gonna go into details. The Comfort 1 study was a randomized, next slide, please. Next slide, please. Okay, that's it. So it's a randomized, placebo-controlled, multi-center, US-based phase 3 study for intermediate 2 or high-risk MF. Inclusion criteria: persistent or refractory to or intolerant to available treatment, and definitely splenomegaly. 1-to-1 randomization, Jakavi 15, 20 milligram oral BID, around 150 patients, versus placebo, 150 patients, and the week 24 is the cut for the primary endpoint. After that, crossover can be done for patients with a more than 25% increase in spleen volume, and this is an important part because, as we'll see later on, they try to analyze also patients who crossed over, if they started on ruxolitinib from the beginning, and if they cross over, if this will impact their survival. Now, patients, what the crossover criteria was patients with a more than 25% increase in spleen volume from baseline. They were eligible for early unblinding.
5 minutes يا بعد منا خالد.
Last 5 minutes?
ايه لانه time is running.
Okay. So
لانه صرت 27 يعني 5 minutes.
Okay, 5 minutes, 5 minutes. So patients, they were allowed to cross over to Jakavi prior to the pre-specified unblinding and analysis. And before week 24, such patient also had to demonstrate worsening early satiety and accompanied by weight loss and worsening of the next slide, please. Next slide. Okay, so what was the primary endpoint? The proportion of patients achieving a more than 35% reduction in spleen volume from baseline at week 24. And the secondary endpoint, duration of maintenance of more than 35% reduction from baseline in spleen volume, proportion of patients who had more than 50% reduction from baseline in total symptom score at week 24, and change from baseline to week 24 in total symptom score, as well as overall survival. Next slide, please. Next slide. Next slide. Okay. So in terms of reduction in splenomegaly, as you will see on the red, 41% and around 97% of patients treated with Reloxetinib experienced a reduction in spleen volume, while 67% of placebo-treated patients experienced an increase in spleen volume. Next slide. Okay, and the reduction in splenomegaly were rapid and durable. Next slide, please. With the reduction in spleen volume were apparent at 12 weeks and were maintained over the course of the study, with 67% of patients who had a reduction of more than 35% in spleen volume maintained it for 48 weeks or more. The same thing applies, next slide. Next slide, please. The same thing applies to the improvement of symptoms. 46% of the patients improved their symptoms, while placebo-treated patients had a 41.8% worsening of mean score. Next slide, please. Next slide. Okay. The same thing applies to all individual symptoms like abdominal discomfort, pain, early satiety, and all the things that we discussed earlier. Next slide. Next slide. Okay. That's خلينا. No, خلينا. Yes. And there was, on top of that, a significant reduced risk of death in Jakavi-treated patients compared with placebo. When it comes, next slide, when it comes to non-hematological adverse events that occurred, it occurred at similar rates in Jakavi and placebo groups. Next slide, please. This is an important piece of information here. The anemia and thrombocytopenia that we encounter in Jakavi. No, half of the grade 3-4 anemia and thrombocytopenia, they occur in the first 8 weeks, and as we'll see, I think, in the last couple of slides, it will not impact the response. So anemia can be treated per se with some of the drugs that I showed you, but on the first 8 weeks, and then it will subside. It will not subside only, it will be tolerated all over the time whenever you are using Jakavi. Next slide, please. So the rates of anemia, as I told you, and thrombocytopenia gradually decrease over time to rates similar to placebo with time. Next slide, I'll not stop here. Okay. At EHA 2016, the long-term outcome of ruxolitinib therapy in patients with myelofibrosis, final efficacy and safety analysis were presented from Comfort 1. And the crossover, next slide, the crossover to ruxolitinib was permitted before week 24 for protocol-defined increasing splenomegaly, and after the primary analysis, the efficacy assessment included durability of the primary endpoint, which is the proportion of patients who had a more than 35% spleen volume reduction from baseline at week 24. Next slide. And if you look at the duration, it continues more than 35 at 5 years. Next slide, please. Next slide. Next slide. as I told you, next slide. ما بقى في إلا couple of slides. So as I told you, the comfort.
Yeah.
خلص
We are time is running. لأنه comfort 1 comfort 2
ما
يعني
خلص
يعني published يعني already.
مش بضطر أقولهم بس مش هيك خليني أكمل.
قد ايه خالد بدك لانه we are running of
خلصت
time
حبيبي.
really.
خلصت.
يلا
very
nice يلا.
Now concerning the comfort 2, the only thing الفرق بيناتهم is the time is 48 versus 24, and this is an important slide. Why? Because the comparator arm that was used for ruxolitinib was in 47% of the patient received hydroxyurea, and 67% one of the more BAT medication, as well as 33% received no medication. The 5-year follow-up duration it was 53.4% in the Jakavi arm, achieved at more than 35% reduction in spleen volume at any time on treatment on 5-year follow-up, and 97.1% of the patient on Jakavi experienced any reduction of spleen volume. 10% for each reduction results in 9% reduction of death. I think I'm not going to continue, but it's just to conclude that the exploratory analysis using pooled 5-year data from the comfort trials, both of them, confirmed that long-term treatment with Jakavi prolonged survival compared with BAT or placebo in patients with intermediate to and high risk MF. I think I stop here. One thing, JAK inhibitors in the COVID-19 era, does COVID influence the use of JAK inhibitors in MF? These are my slides, not the company slide. No data regarding risk with the use of JAK inhibitors. Patient on stable dose with no leukopenia, no change in regimen, and we follow the CDC recommendation. Taking patient off JAK inhibition may increase risk due to disease progression and debilitation. Sorry that I took time, but that's what happened.
Thank you, Doctor. Thank you.
Thank you.
It was a great. I apologize and we pushed too long. It's a question of time, but the presentation was comprehensive, very interesting and comprehensive presentation. Akid. Now we will finish by the last presentation. Professor Fadi Farhat, the president of CRG, CG, and the head of the Hematology Oncology at Hamoud Hospital, Saida. He will talk about Hodgkin lymphoma, new treatment algorithms in Hodgkin lymphoma. Too much or too little? So the floor is yours, and then we'll discuss that.
Thank you very much. I'm trying to find the presentation. It doesn't matter. Khalid, indeed, it was very nice, and don't worry, we took a bit of time, but now we wanted to stop. But it was really very interesting.
Yeah, interesting and extensive.
So I will be talking about I'm trying to find my presentation. I'm sorry. About Hodgkin disease. Give me a few seconds. خلال هالوقت you can go and ask Dr. Ibrahim. Open the floor for Dr. Ibrahim. عم تسمعني أحمد؟
أحمد بسمع بدك إيه عم بسمع
Please بس to find I had a small problem.
طيب we can talk about myelofibrosis. Question is بدك awaiting?
Yes, please.
Okay, so do we have? I don't have on the chat questions, but I would like to ask one question to Dr. Khalid. You talked about ruxolitinib. Ruxolitinib is a good drug for, and this is JAK1/2 inhibitor. But you know, the importance in myelofibrosis also is to arrive to good response to stop constitutional symptoms. Do you think that What do you think about adding something to ruxolitinib, since recent studies are showing that we can add things to ruxolitinib and being more efficient in terms of symptoms and the spleen, SVR, spleen response. سمعتني? You hear me, Dr. Khalid?
I think he's not with us. I don't know.
Khalid ما عم يسمعني.
Okay. If you want, I can start. Huh?
Okay, Fadi.
Thank you very much. So again, thank you for being with us and staying so late. Just since it's an educational, we have to go a little on overview. We know very well that the incidence rate is high and the mortality rate is low, specifically in the younger age. We know very well that it's more aggressive when it comes in elderly age. We know also that, that almost 40% to 48% of patients will have advanced disease, and in developing country it might be more developed. No need to go, but a reminder about the importance of staging one side of the diaphragm, more than one area of lymph nodes from one side, two sides, and extranodal spread. And the 5-year survival from 2008 to 14 were 92% for patients with a stage 1 and 73% for patients with stage 4. So it's important to mention that it's the earliest we diagnosed, the better is the result. And here, mainly a practical algorithm. When you do the diagnosis, you go in early stage for ABVD or Stanford, ABVD or Stanford 5 or escalated BIACOP ABVD. And for the stage 3-4, the same. And you have, in case of refractory or relapse, many options that we are using practically. The main, usually we should go for the combination chemotherapy, but nowadays we have the pembrolizumab or nivolumab, and we have the bendamustine plus brentuximab, which might meet in second line and later. But indeed, we all know that except in some countries like Germany, the ABVD is the most commonly used. That's why we are talking more about the ABVD. And we know that practically, practically in the real life, we go for the ABVD followed by radiotherapy. In favorable, non-favorable, we can extend the number of ABVD, and in some cases go to escalated BIACOP or Stanford 5. And more than that, we can do more than that with the advanced stage 3 and 4. And remember that radiotherapy, even if in different modalities, is still a cornerstone with the chemotherapy. So again, talking about ABVD and why today I'm talking about ABVD and CML. And you know very well that I'm more implicated in solid tumors, but personally, I have a lot of patients, Hodgkin and CML. So that's why I'm interested in such diseases. ABVD in advanced Hodgkin lymphoma, we have a very nice rate of cure, and still we have the relapse rate. And when we give ABVD, we give 2 cycles, which means 4 injection, and we do the PET. If the PET negative, we have a different. We can de-escalate to AVD, and if we have a PET positive, we can either continue ABVD or intensify. And the ABVD, you know, it's the classical treatment. Despite the fact that we have a good results with ABVD, we are still seeing relapse, almost 30% in the advanced stage compared to 10% in the early stage, which is really good. And we know that some other protocols like the BIACOP may be more efficacious with higher results than ABVD in advanced Hodgkin lymphoma, but really the disadvantage is the toxicities on a short and long term. And remember, we are talking about curable disease. So here we have to balance between the toxicity for all the patients while not all will relapse, and between the benefit for some of patients. So it's tricky, and every doctor with his patient will discuss it. And also why in our country it's not really followed, because the type of toxicity might be fatal in our region because of the different follow-up and different kutum awaid of our patients. So look the difference between the BIACOP and the ABVD or the standard or escalated. Look to the grade 3-4 toxicity in green for the infection. Look for the anemia. Really, we have almost no need to compare between the green and the others. And look to the leukopenia also when it comes to grade 4, a huge number of leukopenia. Unfortunately, we haven't seen here in the slide the febrile neutropenia. In all cases, we have to say that the incidence of hematological activity was greatly increased in the escalated BIACOP. BIACOP also will lead to a lot of other toxicities. If we delete the hair loss, which is not a big, which is not a risk in my opinion, you can see that other toxicity like pain, mucositis, neurological effect and skin effects are different between both protocols in favor of the ABVD protocol. ABVD is an excellent protocol. We are using it, and we used it since the promotion, since we started working as hemato-oncologist. But we knew when we started also that the bleomycin is not really a nice component of the treatment. We have to use it, but we are afraid from the toxicity. Remember that almost all the patients, the majority are young, so we should not compromise their quality of life and their life with a pulmonary fibrosis, specifically because there is later on add on the bleomycin, there is the radiotherapy. Up to 25% of patients will develop pulmonary toxicity. So we can say that it will impact the overall survival, and 27% decrease in the number of patients surviving more than 5 years between those without BPT or with BPT. And this is why there was a trial they investigated on a new molecule in order to get better results. So there was in the NCT trial, which was an open label phase 1 dose escalation study of BR plus ABVD or BR plus AVD in patient with in first line. They received on front line. They received up to 6 cycles in an increasing dose 0.69, 1.8, and the cohort 4 was for 6 patients 1.8, 1.2 kilogram with the AAVD, and we can see that here that there was an expansion phase, and the recommended dose after this phase 1 trial was reached. And then after, the decision was to move for the next step, the dose was 1.2 milligrams per kilogram. And the toxicity here, as you can see, was high in both of protocol, with neutropenia in both protocol, anemia, febrile neutropenia more in the AABVD. And also we can see that the other symptoms like neuropathy were more in the AAVD. There is no explanation why more in this protocol. It's like if the bleomycin has a protection effect on the neuropathy. What's very important in the slide is to show that the pulmonary toxic effect was 24% in the combination of BR with ABVD versus the BR plus AVD. So brentuximab really is contraindicated when combined with the bleomycin. From that, the decision was to move to more trials. And before discussing the data of the brentuximab, because again, it's the latest advance in the Hodgkin lymphoma, I would like to recall the importance of the primary endpoints in any trial. And it might be different from trial to another one, but remember that for us as oncologists, overall survival is really the best time, the best endpoint is the gold standard endpoint. Normally, it's easy to measure because when the patient is diagnosed until the death or loss of follow-up, it's easy to interpret. It's evident overall survival better means we have a better drug, and we can. So it's a direct measure of benefit. But we have to say that the overall survival analysis needs a long follow-up. So it's extending the time of the trial, and specifically in some curable disease like Hodgkin. Also, we have to say that death from any other disease will also confound, will compromise the overall survival in such a situation. And also the treatment, later treatment, also will impact on the analysis of the overall survival, since the patient might receive different lines of treatment. And finally, the overall survival analysis can be confounded. You can see it in dark. OS analysis can be confounded by changes in therapy that occur prior to disease progression. This is, in my opinion, specific to the Hodgkin disease. I think it's the only disease, mainly the only disease, that if you do not reach the complete remission, you have to change the treatment. Maybe like the CML, if you don't reach the MMR, you might change the treatment. In Hodgkin disease, it's an obligation. So based on that, we can say that the evaluation of PFS, it's really when we do that, we are missing a point of the importance of such any protocol, because when you start the treatment until the progression of the disease, or until the death of any cause, or until the completion of the first treatment, we count the PFS, not the completion, the progression of the disease, we consider it as PFS. But if you look well, let's see for the patient who will progress, the PFS is from the starting, from the start of the first front line up to progression. It's recorded as an event. We call it's any event, progression or death or modification of the treatment, etc. It's the PFS here is clear. It's from the beginning up of the treatment till stopping the treatment due to the disease progression, or it's the PFS from the start till the death of any cause. So this is recorded as an event, and it's a disease progression, as you can see from the front line. And here the patient who will not achieve a complete response, as we can see in this slide, will go to another line of treatment, subsequent anti-cancer treatment. So if the patient has a score of 5, Deauville score, he probably will modify the treatment. He's not in progression, so it's not considered as an event like here recorded as a progression, but still he is receiving another line, and we will say that the PFS is recorded on the next disease progression. So this will lead to this will push for missing the importance of the first line treatment, since we are adding another line, which might be the reason why the PFS is improving. And it was demonstrated that if you compare the PFS to the MPFS, and what's the MPFS? I will go back and show this slide. This is the MPFS. If you consider any modification of the treatment or the failure to reach a CR as an event, so we can consider here the modified PFS. So if we take this modified PFS and we compare it to the classical PFS, we can see that we are really overestimating the PFS in this case. This finding will show how the standard use of PFS may be effectively rescued by subsequent therapy, artificially enhancing the PFS result achieved by initial chemotherapy alone. So again, we are overestimating the PFS if we go and evaluate the real MPFS, the modified. So again, the modified PFS is defined as time to progression, death, or evidence of non-CR after completion frontline therapy. It's evident and it's clear. So that's why, knowing now that we have a new parameter for evaluation, and also since we know that we have a new drug, which is the brentuximab vedotin, BV, a trial was initiated to compare the efficacy of AVD versus ABVD. So it's a big number of patients. The inclusion criteria were no previous treatment for Hodgkin lymphoma, age more than 18, stage 3-4, ECOG 02, and a patient received one of the two arms. So it was a randomized trial 1-to-1, and for sure PET scan at the end of second cycle should be done, and the Deauville score should be evaluated. And if the Deauville score was 5, then the patient can be switched to another treatment. And then the follow-up every 3 months for 3 years, then every 6 months. The endpoint was the modified PFS and the primary, the secondary OS. And here are the protocols. We don't need to see it, but there was a stratification based on the IPS risk and in the region. And look, it shows a difference between AAVD in blue compared to ABVD also. We can say that the primary endpoint was met. The hazard ratio was 77, which means 23% decrease of progression with a borderline P004. But remember, I'm not talking about pancreatic cancer. I'm not talking about renal cell cancer, where the responses are low. I'm talking about Hodgkin disease, where the rate of response is very high. So any advances in the PFS or OS will be welcomed very really seriously, and any progression, any amelioration of the toxicity profile will be also welcomed. Remember, when we started with the treatment of Hodgkin disease, we had the toxicity of radiotherapy, and we all remember this patients with the deformed thoracic cage. So in my opinion, 23% reduction of progression is important. And here The 2-year modified PFS was 82 versus 77. And if I have to say that the PFS was maintained at 4 years, this is also important. So at 4 years, we are still having a difference about 6% between both arms, and the hazard ratio showed a 31 reduction in progression or death with the studied arm compared to the ABVD classical arm. So very nice, and PFS was maintained regardless of the inclusion or exclusion of modified events. Not to go through it, but you can see that wherever you analyze, however you analyze it, we have similar results with the improvement to the AAVD. And the overall survival was numerically high, but statistically not different. The p-value was 0.2, and we can say that in the ABVD classical there was more death. The Echelon-1 trial, the AAVD regimen reduced the need of second-line treatment. This is what the 2 years analysis. So subsequent anti-cancer therapy was less in the arm of AAVD, 69 versus 99. High-dose transplantation, chemotherapy transplantation less. Radiation the same because the same indication. It was well balanced. And immunotherapy, which is really nowadays an excellent treatment for relapse of Hodgkin disease. We all used it, and we all are very happy of results. Was also less used because probably of the success of the treatment at 2 years in the arm AAVD. Very busy slide, no need to go through it, but all the parameters subgroups were in favor, even if it was equal in some of these parameters. What I like to show this slide, the hazard ratio was more expressed in the high risk population. So high risk features showed better benefit from the AAVD. What does it mean? It includes the patient with the stage 4 disease, more than one extranodal site at baseline, or high IPS score. So all these patients had got a great benefit from the AAVD. So the hazard ratio was 0.77 globally. For the stage 4, it was 0.71. Look, with a significant p-value. More than one extranodal site, it was 0.70. So 30% reduction of deaths. And for the IPS, high IPS, also 30% reduction of deaths. So remember again that that's the reason probably why in Europe it's approved only for stage 4, which is considered as high risk. When we look to the PFS compared to the MPFS for the stage 4 disease, we can say that the assessment of the traditional PFS confirmed the benefit demonstrated by the modified PFS analysis. What do we mean by that? You can see that the PFS seemed better. Also, the MPFS. So in stage 4 or in more than one extranodal site at baseline, the MPFS, if we use the MPFS, it's better to use AAVD. And if we use the ABVD, classical ABVD, also it's better. So here, just to show that it's not the study or the results are not biased. Talking about toxicity, I would like to say that I would prefer to go to this slide. There was fewer deaths with AAVD compared to ABVD, and you can see here 1% compared to 2 for ABVD and the total population. And also, I want to say that the peripheral neuropathy was higher in the AAVD arm, as you can see here. For the grade 1, 2, and 3, we can see that the AAVD was a higher neuropathy. And also to mention that the neuropathy resolved in over 4 years. 4 years of follow-up, it's so long, but remember, these patients are cured, and a transitory toxicity like peripheral neuropathy is better than permanent toxicity like lung fibrosis. And also there was a more neutropenia, but it was manageable with the GCSF treatment if it was proactively used. And the death finally, and the death were more prominent, were higher in the ABVD compared to AVD during treatment and during follow-up. So it's again important to mention that the reasons were in the ABVD arm were due to the pulmonary-related pulmonary toxicity, and so mentioning the importance and the seriousness of the bleomycin toxicity, also due to cardiopulmonary failure or unknown cause. So again, it's important to mention that. And look why we should use GCSF, no AAVD without GCSF, because we had some death with neutropenia. Think that we can avoid easily by the use of the GCSF. So in my opinion, we have only to talk about 2 of 9 myocardial infarction, which is probably due to the adriamycin and nothing more. While in the ABVD, we have 11 on 13 due to pulmonary toxicity and 1 over 13 due to cardiopulmonary failure. So 12 cases due to the pulmonary toxicity. So for sure, we have to blame the bleomycin and not it anymore. More severe with ABVD, we know that. There was an increase in the incidence of febrile neutropenia compared to the ABVD at this time. I think it was not supposed to use the GCSF systematically in the trial, but practically now we have to use it. But there was no death associated to neutropenia in case of patients receiving GCSF in the trial. So it's very important. I insist on that again. The dose delays and reduction will be delayed also, and hospitalization will be delayed by the use of GCSF. So here to show that the GCSF prophylaxis may be associated with superior modified PFS. Why? First of all, because we have no death from febrile neutropenia if we use the GCSF. Second, because if we complete the treatment, we know the importance of dose intensity in Hodgkin disease, and this means we are giving the treatment at time. So you can see the excellent improvement in MPFS for patients receiving the AAVD compared to GCSF. It's better than the AAVD, and it's a lot better than ABVD. So this means that, in my opinion, don't use AAVD without GCSF. Okay, and you can see that the difference was significant. The hazard ratio was, when you use GCSF compared to ABVD, it was 0.58, the hazard ratio, which means about 42% or 41% decrease of progression. Okay. So what's the main message from this presentation? Hodgkin disease is a serious and incurable still disease in some cases. We have up to 30% which will fail the frontline therapy. We have many therapy, but they might toxic, so we still are using mainly ABVD. We have to differentiate the primary point in Hodgkin compared to others. The AAVD combination, brentuximab, adriamycin, velbe, and detisan, could improve efficacy compared to the classical ABVD regimen, and the modified PFS as primary endpoint was improved in this trial. And remember, the use of GCSF is a must in such cases. With that, I finish my presentation, and I thank you very much.
Thank you, Dr. Fadi, for this elegant presentation, particularly the update of Echelon 1, an important induction therapy in first-line therapy in Hodgkin lymphoma. Now we have a few minutes before closing for a panel discussion. The two panelists are Professor Nasser Abdelbari. He is Professor of Clinical Oncology and Nuclear Medicine and Vice Dean of Education and Students Affairs, the Faculty of Medicine at Menofia University in Egypt. And Assistant Professor Akram Karma is a consultant hematologist and bone marrow transplanter at the Arab Hospital and the Beit Jala Hospital. And he is assistant at the faculty of Al-Quds University, Palestine. So we have a few minutes to discuss the two presentations, the MF and Hodgkin.
Thank you for this nice presentation. Actually, I have a question for Dr. Fadi about the brentuximab in Hodgkin. What you think about consolidation brentuximab in first line after AAVD? There is any rule for consolidation?
It's very interesting question. And usually we do not suggest, even if it's an inhibition of the CD6, it's important, but I don't think that we have to use it outside the trial. And
yes, exactly. The only maintenance therapy is
after transplant.
Approved is Athera study post-auto transplant, published and revisited and updated this year. We're used one cycle every 3 weeks for 16 cycles.
Yeah, sure.
Outside, no trial is published on this.
Okay. Second question about the advanced stage. In our countries, Lebanon, Palestine, Jordan, low-income countries. We saw in your presentation the difference was 6%. It is. Do you see this is feasible in our country to go to such this medication we know is expensive? We can use ABVD, we can use, and the difference is not too much, 6%. It's not that's what do you think about low income like our countries?
Yes, I totally agree. Just a reminder, the Tasiva was approved in pancreatic cancer for 15 days gain. The Novantron, mitoxantron was approved in pancreatic cancer and prostate cancer just because of quality of life. Gemcitabine was approved in pancreatic cancer just also for quality of life. I totally understand your concern. Indeed, we still are using ABVD when we cannot afford the brentuximab first. Second, I think this trial should be not repeated, but analyzed differently. When you look to patients with high risk features, you see that the difference is major. It's 30% decrease in the progression. So in my opinion, it might be interesting to use such medication in stage 4 because you are gaining PFS, MPFS, and I think it's important for active people. You are talking about very active people, young people, and I prefer to put it in this place in order to gain 6% and not in advanced lung cancer for a patient with 70 years old. So I totally understand. It's a matter of cost health economy issue. But when you can afford it, please do it. And by the way, Dr. Akram Karma, I would like to tell you that we are really very happy to have you with us today from the
Thank you.
I think all our friends are very happy. Thank you.
Let me add something very important that was highlighted by Dr. Fadi. If you can afford it, and it could be interesting to use it for stage 4, but very aggressive stage 4. More than one site, extranodal, 4 or 5 to 7 factors. In this case, you have more than 6%. You have more, and you have a significant higher modified PFS, and the time to relapse to second treatment is higher. So in this part of stage 4 of advanced disease, it is more interesting than the whole 3 or 4 in general associated.
Last thing about stage 3 and 4. If you don't have, I give some patient brontuximab in stage 4, but if I have the 2 option escalated and ABVD with severely symptomatic patient, would you give escalated or ABVD? B symptom.
In young with stage 4B, 4B with what kind of features of factors?
B symptom.
All the 4 are not similar.
Let's say more than site of extra nodal. Yes, that's what you want.
If the patient is not elderly, is young, without comorbidities, if you go to escalated, I think that escalated BCOB is more interesting than ABVD alone. In this case, I'm more with Köln than with the USA approach. And we know that with escalated BCOB, then you can de-escalate. So if the patient with a PET scan after 2 cycles is in complete remission or less than Deauville 2. The problem in the follow-up also is this very important, the Deauville 3 is equivocal for the evaluation. 1012, we are safe. Deauville 3 appear more and more equivocal, and for this Deauville 3, after response, we have to put adequate aggressive therapy in order to have better response. So the question is the first line and the follow-up.
Dr. Mustafa is here.
I would like to ask Dr. Khalid is with us. Dr. Mustafa, Dr. Khalid is with us for myelofibrosis.
If not, you can ask the question and answer.
To discuss. No, I would like to add the panel. We can discuss about using of ruxolitinib not alone in patient with myelofibrosis as first-line therapy. We have comfort 1, we have comfort 2. We know that there is a limit for the spleen, for the constitutional symptoms, and we can lead some patient to allogeneic transplant. But I think that we have to go beyond ruxolitinib alone. And we have to go to associate ruxolitinib for many patients with other treatment. We talked about anemia. Now the results with Luspatercept for anemia are good. The emerging results in this year are good for anemia, and we can have a less transfusion dependence, significantly more than 50% at 24 weeks, which is very good compared to ruxolitinib alone.
Très bien en comparant avec ruxolitinib seul. On va penser à BCL2, Ramitoplas.
Not bad. We can think also by adding some other promoting megakaryocytosis and stopping promoting erythrocyte, like I think that MD Anderson published, or in the United States of America, a multi-center study was published recently, presented recently with CPI 061. So we can think, and in this educational session, we have to say that beyond ruxolitinib in the near future, we will have with ruxolitinib something else or beyond in order to have better spleen and better eye, symptoms, better improvement in symptoms.
Yeah, you're right, because a lot of data now is being overseen. A lot of yeah, sure. ما لك انا بس انت ما لحقت تشوفني انت.
دكتور احمد اعطيه فرصه.
هلا لانه هلا خفت ما يكون في رشاش طالع من التلفزيون فزحت.
وخي مكتوب كي وبقلب موف.
كوكلس كلان هيك يعني. طيب لا بس انه it's a very interesting point actually.
Ceci est un point très intéressant.
What's happening in myelofibrosis and namely whenever you are talking about ruxolitinib, I think the time is expiring.
Je crois que l'essai est en train de d'avoir plusieurs facettes. Ce que vous êtes en train de dire, il y a une combinaison.
A lot of other molecules.
On a plusieurs molécules.
Both of them
Navitoclax
are being explored.
I'm exploring
a lot of things, either alone.
Je suis soit seul, ce médicament doit être fait ou en combinaison.
The drug that was approved in thalassemia now for the treatment of
faire un traitement d'anémie
approach, and actually it's approved.
Ceci est une approche très tentante. C'est approuvé pour usage, mais le problème de l'anémie, malgré le fait que c'est indiqué sur les slides, on peut le surpasser sans affecter les résultats. Parce que certains des patients vont avoir de l'anémie et il est très difficile de les contrôler. Il y a personne qui utilise Jakavi, mais ils ont toujours l'anémie. Et la deuxième question,
this kind of approval that we got from
que nous avons eu. C'est un
50,000, and by the way, it's important because less than 50,000 is always hazardous. But I will use your presence as transplanters to ask two questions. Actually, if we have 5 minutes, the first of all, how much do you like to have a splenectomy for a spleen more than 15 before transplantation? This is one.
It's a very important question. Yes.
This is
a very important question. Do you go to transplant to the big spleen or no?
Yeah.
Some people do surgery then go quickly to transplant after splenectomy. Some other people do radiotherapy and go to transplant. If the spleen is not very, very high, you can go with ruxolitinib then transplant and continue ruxolitinib post-transplant. Though the interest, so this is a very important question. We don't like to have big spleen before transplantation. We know that the complications are more here, control the disease is difficult with a big spleen. This opened the way to new drugs with ruxolitinib or to new drugs beyond ruxolitinib.
As neoadjuvant,
and as first-line therapy before transplant to reduce as soon, for example, with the PCPI or navitoclax, you can arrive to a kind of a 70% quick, relatively quick SVR, which is important, which is not with ruxolitinib alone. So we have to investigate the new drugs, this new combination, in order to arrive with a good spleen to transplant the patients.
Yes, yeah, sure.
Can we have the opinion of Dr. Akram and Dr. Shwan if they want to express the Dr. Okay?
بس one point على سبلينوميجالي before الترانسبلانت بصراحة أشياء كثير ممكن تتسوى يعني الجكافي as bridging ممكن 2 to 3 months من عمل bridging. السبلينكتومي يعني always we trying to avoid it عشان الكومبليكيشن.
See, there are some teams who do it and to go to transplant if they are experimented in splenectomy.
كيف؟
في ناس a big discussion. Transplantation group last year. What about this? Some people, some experimented people, like it's a spleen, big spleen, and experience a team, and they go to transplant. It could be feasible. This is not feasible. يعني بكل المحلات.
بقى يعني برضه الراديشن يعني هيك
أو الراديشن يعني
اوبشن الامبولايزيشن even يعني sometimes
يعني this is an open question.
It's
an open question.
I think I don't know if I can intervene here. Platelet count is also important. If platelet count is less than 50,000, this justifies splenectomy or splenic irradiation prior to transplant. Otherwise, I don't think it's a proven efficacy before transplant.
If you have 50,000, you have the patient with a big spleen, not a small one. So you have to act.
Yes. Yes.
Yeah, but all the discussion is now being had in the context of transplant, because otherwise no one is gonna do a splenectomy for a patient if you're not contemplating to transplant. That's why my question, because as transplanter, you know better than me that engraftment will be a problem and the complication will be.
كل ما يكون splenic bigger, the engraftment is longer.
Sure.
Yes.
I think in the future, in the near future, what appeared that using new drugs going beyond ruxolitinib in order to have a spleen response, a good spleen response maintained, and in independency, relative independency in transfusion.
My question, Dr. Fadi, regarding Hodgkin lymphoma, what's your opinion regarding the optimal introduction or optimal role of radiotherapy in Hodgkin?
We have with us Dr. George Farha. I think he's with us, and I would like to have his opinion. He's a radiotherapist. George, are you with us? Vanessa, can you give the hello? Okay. Vanessa, can you give the panelist options to George Farha? So indeed, we are using the radiotherapy, and nowadays we are decreasing the dose, as you know very well. But what's exactly your question about the radiotherapy? What's the role of radiotherapy?
For example, in the early or the favorable type, we usually mention plus or minus introduction of radiotherapy. When you use radiotherapy in the favorable group and when you use it in
Indeed, usually I keep this for our radiotherapist to decide. I don't know. Yeah, and I don't know if my colleagues here, Ahmed or Khalid or Shwan, will answer this question.
Yes, I think involved site radiotherapy is the only left option as radiotherapy for Hodgkin lymphoma now. Other modalities.
The involved side is very difficult for radiotherapy. This field, why? Because they need the PET scan initially and in the same position when they want to give. But I think in the NCCN guideline, it's clear when you can drop the radiotherapy and when you can continue with the radiotherapy. And I think always nowadays we like to omit the radiotherapy if there is good initial response. If you agree, Dr. Fadi.
Well, these are the guidelines.
I agree, but indeed, what we do is in the multidisciplinary discussion, we keep it for the radiotherapist. And indeed, I'm not really involved in that. I know that for the favorable cases, we might skip it, but it's hard to make the decision from our side. Maybe if you are working only in lymphomas, you have the experience. I personally will not decide for that.
My question, because the decreasing the dose of radiotherapy with expected less side effects or toxicity from this lower dose could make its role taking a wider use, especially as you know, previously we were using beyond the 36 grays, but now we can use only 25 with less toxicity.
Still, the question is, can we avoid it at all in some cases? Ahmed, you are muted. You are talking but muted. Ahmed Ibrahim.
لأنه عم تقطع من الحلقة. One comment. I like a comment of Dr. Akram for radiotherapy. We know that randomized studies are ongoing, and now we have to wait also to have the long-term follow-up for radiotherapy for very favorable group. If you want to use ABBD 2-cycle radiotherapy 20 versus not 20, and the German group is very, and in Europe those studies are very, very interesting. The importance is
pour l'étude allemande, la réponse est très bonne, les pronostics sont très bien, mais si on peut nous empêcher,
we intend to do it for the
nous pouvons le faire
going to 2025.
en donnant 20-25. Ceci est une approche mais bien. Nous avons besoin de parler de... C'est quoi les instructions des guidelines ou les orientations?
Groups. That's the question.
Ceci peut être dans
NCC
les
groupes, I think
favorables.
It's clear for this issue. And actually, in our area, we try to avoid the radiotherapy because the difficulty.
On doit prévenir la radiothérapie. Il faut toujours donner la chimiothérapie parce que la radiothérapie, les personnes doivent aller dans des checkpoints pour arriver à Jérusalem et tout ça. Donc, c'est un problème. Il faut suivre les guidelines, mais on essaye de donner les...
Okay, so you are
في عندكم الجايدلاينز وفي عندكم what is
Vous avez les guidelines et vous devez donner les réponses selon les études. En général, les guidelines sont des guidelines. Quand c'est mis en 2021, ils sont donnés en 2019. Donc,
for example,
ceci ne s'applique pas au Liban. Le AVD est comparé à Pembro.
Dans le futur,
on peut donner peut-être sans chimiothérapie pour certains patients. Les guidelines ne sont pas appliquées sur tout le monde ou par ICCN à tout le monde. Donc, les groupes de lymphoma, les décisions, tout ça. Donc, cette approche de radiothérapie est presque favorable et les patients répondent, s'ils sont en train de faire des réponses, ils n'auront pas besoin de radiothérapie. Comme le EPCR ou le EBBD. Si on peut le prévenir, ça serait bien, mais sinon, l'approche doit être plus favorable. La probabilité n'est pas... il faut suivre les guidelines.
Do it, but I know very well, Ahmad, I know very well that there's a lot of ongoing trial, but
il y a des essais, mais on ne peut pas les utiliser. C'est une activité. La question est, est-ce qu'on doit le faire ou pas? Si il y a un favorable, et pour quel patient? Je sais qu'il y a des essais en continu, mais on a l'overdose, on a aussi. C'est quoi le problème ici? Le problème, c'est la réponse, la thérapie.
على الراديوثيرابي او انك تكمل كنت
c'est la radiothérapie ou la chimiothérapie. Ce sont les études allemandes. C'est pour cela, Dr. Akram, ce que Dr. Akram a dit. Mais je vous écoute pas bien. Tout est observé.
هذه مش هذه النودولار، هاي نودولار ليمفوسايت.
النودولار والثاني خد غير النودولار ليمفوسيتك برودومينانت، خد الثاني،
هات
خد
الثاني،
الميكس سيلولاريتي،
هات الثاني. وين هي؟
ميكس سيلولاريتي الثانيه. هو مش بس الان سي سي ان الجايدلاينز، في الاسمو جايدلاينز وفي اذر جايدلاينز، بس الان سي سي ان انه عندكم اياه
راح من قدامنا.
راح لانه هيدي كانت
راحت الجايدلاينز،
راحت الجايدلاين. ايوه
وانا عم تروح الكنبه.
هيدي بعد النودولار،
هذه النودولار. افتح على
النودولار ما كثير فريكوينت نودولار.
لا النودولار فيري رير، واحنا النودولار اوكي يعني ماشي فيري رير.
We will not find the next. It's okay. Let's.
لكن بلا حتلاقيها بالاول، حتلاقيها بالاول.
Je m'excuse, mais quand ils parlent tous ensemble, moi je peux pas traduire. Je suis une seule personne contre 5 qui parlent. Excusez-moi, ils discutent, moi je peux pas traduire tout le monde. Hein. Donc là, il y a une discussion entre tous les médecins, mais je suis désolée, je peux pas suivre. Apparemment, ils parlent d'une étude. Ils sont en train de mettre l'étude en ligne.
على ديوفيل 1 to 2 كيموثيرابي الون او الكومباين
La
موداليتي.
chimiothérapie seule ou la thérapie avec modalité combinée ou la... Ils vous donnent les options, ils disent. Donc, Dr Brahim dit or, c'est-à-dire ou. Donc, Dr Karma lui répond la combined modality. Donc, c'est pour cela on a dit le Deauville, c'est très important. Donc, chemo alone ou BVD, combined modality ou pas. Je crois qu'il faut trouver les équipements.
And the experienced personnel,
Il faut aussi voir l'expérience.
وكل الموداليتيز موجودين. Do you
Si toutes
irradiate?
les modalités sont présentes,
It depends.
أنا بالنسبة لي
Smoker, for example, radiation is contraindicated because of risk of lung cancer as it dramatically increases.
This is one comment.
ceci est un des commentaires, par exemple. Ceci est un des commentaires dans le PCCN. Le sujet existe. Donc, il faut l'étudier.
This guideline مش إنه على يعني
Ceci est parmi les guidelines.
You are pro-German. برو الاكيب تبع كولونيا، انت بيحبوك كثير بكولونيا. حتى بارت من بارت من السي ال جي بي، حتى بيحبك بارت من السي ال جي بي كمان.
Donc, vous faites partie de l'équipe. Ce qui est important dans les phases premières, comme Greg par exemple, il faut avoir un facteur pronostic et un agenda.
Female ou la male?
Si c'est un female ou male. Si c'est féminin ou masculin, il faut être plus sûr. Dr Ahmad, je ne prendrai pas une décision sans un conseil multidisciplinaire, mais la décision, le radiothérapeute ne viendra pas vous dire je vais faire. L'hématologiste, l'oncologiste, ils ont fait un guideline et à Stanford, à Paris ou Europe, mais Ahmad, là apparemment il y a une discussion entre Dr Fadi et Dr Ahmad. Dr Ahmad, il a son opinion. Dr Fadi, il essaye de lui dire qu'on doit insister sur une approche multidisciplinaire. Dr Ahmad lui dit sûrement, oui, il lui dit, Dr Fadi lui dit, Dr Ahmad lui dit un cycle ou plusieurs cycles. de ABVD. Et puis, Dr Fadi lui dit, on peut discuter ceci parce que la décision dans des maladies curables comme ça est très intéressante pour être faite avec plusieurs collègues. J'ai des patients qui n'ont pas eu de radiothérapie. J'ai des patients... Dr Ahmad lui répond.
أحمد خليهم يحكوا.
بس بدي كنت اسالك سؤال بالديسيجن.
اللي يحكي السيد
Dr Ahmad, s'il vous plaît, lisez ce qui est écrit sous les considérations importantes, tout ce qui est rectangle. Regardez ceci, regardez le deuxième point en général, tout ceci en général. Donc, vous pouvez prendre en compte tout ça. Vous devez prendre en compte tout ceci. Les comorbidités, tout ceci. Ceci, c'est la médecine, mais je demande à Fadi. Fadi, vous êtes allé au conseil multidisciplinaire. Je veux que vous lisez le deuxième point. En général, le traitement... Et lisez le deuxième point, ce qu'il vous explique. Ceci est en général. Docteur Fadi, si vous avez une patiente ayant 2 ABVD et elle est favorable et elle est allée en multidisciplinaire, Docteur Fadi, il a dit, je ne veux pas les vaincre. Qu'est-ce que vous allez faire, Docteur Fadi? Je peux lui dire, bien sûr, parce qu'elle le connaît, mais si elle vous dit, si je les prends, c'est la même chose, elle ne va pas parler au multidisciplinaire. Je vous dis non, vous pouvez l'arrêter, mais cette décision doit être discutée et toutes les options doivent être discutées. Qu'est-ce qui est possible, qu'est-ce qui n'est pas possible, les avantages, les désavantages quand vous choisissez un traitement. Il ne faut pas choisir uniquement l'efficacité, mais la tolérabilité. L'oncologie, c'est l'art de traiter les événements adverses. Comment traiter vos patients? Et mais il y a des feintes qui arrivent. Dr Fadi, le multidisciplinaire n'est pas toujours là. Parfois, il peut être négatif. Des discussions en Pologne. La chimiothérapie, l'immunothérapie. Gaz, c'était très excellent. C'est 4 heures de discussion. On vous remercie tous.
We enjoyed عن جد والدiscussion enjoyed لازم نعملها أكثر وأكثر.
Thank you very much.
Et cette discussion doit être répétée de plus en plus. Je vais conclure.
نعمل أكثر هيماتولوجي بالأي بي سي.
طيب إن شاء الله. Thank you for Dr. Ahmad, Dr.
Merci
Shwan,
Dr. Ahmad, Dr. Shwan et les autres docteurs.
Dr. Nasser, كلكم.
Dr. Nasser, tous, merci.
With that, I will close the session.
Je vais clôturer la session. Merci aux audiences qui sont avec nous.
Thank you for Sciences Pro, his
Merci à Sciences Pro, les organisateurs.
خاصة لجميع الأصدقاء في الأردن وفي العراق.
Merci aux amis en Jordanie, en Irak et en Palestine. Et merci.
شكرا. نشوفكم على خير إن شاء الله.
Previously untreated stage 4 Hodgkin lymphoma patients can present a range of challenges. Patients treated with the standard treatment with doxorubicin, bleomycin, vinblastine, and dacarbazine, or ABVD, has a failure rate of approximately 30%. In addition, ABVD is associated with unpredictable and potentially fatal bleomycin lung toxicity. Moreover, patients who fail initial treatment are likely to endure additional treatment, exposing them to additional risks. But there was never a problem that could defeat Sunrise or Hope. Echelon 1 trial carried a new hope for patients with stage 4 Hodgkin lymphoma.